Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, it's my honor actually to start the first parallel session dedicated to endometriosis, and I'm honored actually to be co-chairing this session. I'm Shalabhani from the Ain Shams University in Egypt, with our expat Egyptian Canadian Professor Mohammed Bidawi from Vancouver, Canada, and as well with Professor Raglan, the chairman of the Tanta University Department of Obstetrics and Gynecology. And there has been a little change in the program, so actually Professor Surur has delivered his talk this morning, and we have a replacement with a virtual thing from Professor Botrus from the United States. So
Well, thank you, Professor Amr, for chairing this session with us, and I think we have to do some adjustments. So our next speaker is Dr. Kennedy. Just as our surprise. We have to make use of your diligence and being on time, so I apologize. Our virtual speaker is yet to show up, so if you don't mind, I would have the honor to introduce you. So Professor Kennedy is a consultant gynecologist and specialist in reproductive medicine, and is currently medical director of the Birmingham Maternity System. He's honorary consultant obstetrician and gynecologist of the Birmingham Women's and Children Hospital. So that's what I was given. I'm really sorry about that. So I was thinking. Well, obviously it's evolving until this moment, so apologies for. Well, it's enough to say Stephen Kennedy, I think. Please, go ahead.
So, first of all, thank you again for the invitation to come and speak. This talk, I suppose, is an extension of some of the concepts that I tried to put across yesterday, with a focus on what's new, if anything, in the diagnosis of endometriosis. These are the 5 topics that I'm going to address during the course of my talk. What's the role for laparoscopy? What imaging methods exist? What non-invasive biomarkers have been developed for the disease? And then more philosophical questions, really. Namely, what actually are we trying to diagnose? And lastly, is there any value in an earlier diagnosis, given that, as we all know, there's tremendous delay in making the diagnosis because of the need to use laparoscopy? So, as I reminded people yesterday, we've moved on since 2005, when Charles Chaperon and I contributed to the first ESHRE guideline on endometriosis. 2 versions subsequently, the last published just a couple of months ago. And the slightly depressing news is nothing much has changed. Except for this. In 2005, we were under considerable pressure, I think, to make this statement. If you want a definitive diagnosis, you have to perform a laparoscopy, unless, of course, there's disease visible in the vagina or elsewhere. In 2022, however, the guideline committee, of which Charles and I are no longer part, have made this statement: laparoscopy is no longer the gold standard. And then, slightly oddly, in my opinion, it's now only recommended if imaging results are negative or where empirical treatment was unsuccessful or inappropriate. So what exactly is the problem with laparoscopy as the gold standard? Well, I've tried in these bullet points to put across what I think are some of the problems with trying to establish laparoscopy as the gold standard. False positives, false negatives, particularly if lesions are missed, and also the concept that you are looking at a snapshot of the woman's pelvis, and that pelvis may change in appearance in the coming months or years. But there is a tendency to almost brand the woman as having a disease based upon a laparoscopy that may have occurred years beforehand. Of course, there are costs, in particular morbidity and mortality. And lastly, the assessment of the pelvis visually is troubled because it is so difficult to assess and report and record the severity of disease that's present. All of you, I'm sure, are familiar with this ASRM classification system, but in a systematic review published last year, even I was astonished to learn that there are 22 disease classification, staging and reporting systems published between 1973 and 2021. Astonishing that there are such variety in our attempts to record what's found at laparoscopy. And no consensus, to the best of my knowledge, as to which system is best and which system should be used in routine clinical practice, let alone research. So what does the ESHRE guideline currently say about imaging for endometriosis? Well, this is the statement for all of you to read. And it's a strong recommendation. But of course, a negative finding, as we all know, does not exclude endometriosis, particularly peritoneal disease. And then the group statement is made that if the findings are negative, then consider performing a laparoscopy to diagnose and treat endometriosis. And there's something rather convoluted about this. You know, the statement that laparoscopy is not the gold standard, but however, if imaging is negative, then go ahead and perform one. To discover what? And that's an important clinical question, I think. So the diagnostic accuracy of both transvaginal ultrasound and MRI, as stated in the ESHRE guideline, is based largely on two Cochrane reviews. The first here showing, unsurprisingly, that ultrasound has greater sensitivity and specificity for ovarian endometriosis than it does for general disease in the pelvis. And likewise, in the second review, the diagnostic accuracy of MRI is greater for endometriomas than it is for general disease in the pelvis. Really nothing new that we haven't known for many years. What about biomarkers in blood? Well, this was a systematic review that we published in 2010 showing the countless, over 100 biomarkers that had been described in the literature, most in pretty poorly performed studies with small samples. The conclusion we drew in 2010 is we are yet to discover an effective and clinically useful non-invasive biomarker. Subsequently, 2 Cochrane reviews on the diagnostic accuracy of non-invasive biomarkers, with more studies included. For example, in the top part of the slide, 141 studies involving over 15,000 patients, looking at 122 blood biomarkers, and this is the conclusion: none of them were accurate enough to be clinically useful. And then as far as endometrial biomarkers are concerned, the systematic review identified 54 studies involving 2,000, nearly 3,000 patients, 99 endometrial biomarkers, and the conclusion was that, well, some of them potentially might have some diagnostic potential. One other systematic review published a few years later, looking at microRNA in the peripheral blood. 9 particular circulating microRNAs were identified, but no single, this is the conclusion from the systematic review, no single microRNA or panel met the criteria to be a diagnostic biomarker. So unsurprisingly, the ESHRE guideline was very specific that clinicians should not use the measurement of any biomarkers in any of these tissues to diagnose endometriosis. And their specific research recommendation, based largely on the fact that most of the studies in the literature had been poorly conducted with small sample sizes, was, as you see here, the need for large, multi-center prospective studies with independent validation of samples to fully investigate the potential of biomarkers. Now, a major contribution, I think, to the research literature was this World Endometriosis Research Foundation protocol, which was published in 2014, although I don't know to what extent this excellent protocol for how specimens should be collected, processed, and stored in endometriosis research, I don't know to what extent this excellent protocol has been followed because of, it should be followed because of the need, the absolute need for standardization in the way in which samples are processed, let alone how those samples are analyzed. And I think that's an issue. Oh, what's happened? That's an issue. Has that been the case all along? That's an issue because of someone mentioned yesterday during the talk that BCL6 overexpression in utopic endometrium is now a and indeed it is being marketed around the world as such by this company Receptiva DX. Although this is based upon a small study that was published a few years ago showing overexpression, as you can see in section E in the endometrium of BCL6 compared to the endometrium of women without endometriosis. However, my reading of this literature is that there's enormous confusion. BCL6 overexpression is indicative of inflammation, admittedly. However, it's not clear in the literature to what extent overexpression is confined to women with endometriosis or is to be found in women with unexplained infertility in general, or those with reproductive failure at IVF, or those with recurrent miscarriage. And that seems to be borne out by the 4 bullet points on the right, which I actually took from the Receptiva DX website. This test can only be performed in one center in the US, although the reach appears, on their map at least, to be global. So let me end by talking philosophically, because I've been involved in endometriosis research for many, many, many years, and I continue to ask myself these questions. What exactly, as clinicians, are we aiming to diagnose? All endometriosis? Yeah. Or only, tiny little spots? Recurrent disease? Disease that might occur in the future in those women that are most susceptible? And which women? Symptomatic women? Women whose symptoms have come back after successful treatment? As a way of monitoring the effectiveness of treatment, and then, perhaps in those who are at risk, may even be asymptomatic now, but would appear to be at risk because of a strong family history. And these are extremely important questions, because, as is the case in every other field of medicine, the performance of any diagnostic test will vary depending upon factors such as this: disease severity, whether the patient is symptomatic or not, indeed what those symptoms are, time of the menstrual cycle. Some of you will recall the way in which that was demonstrated with serum CA125. And lastly, the type of the population. And finally, from a population and health systems approach, not just with the consideration of the individual patient, one has to ask these 5 questions, as indeed one does about trying to diagnose any disease earlier than is currently the case. These, I think, are very important questions. Will diagnosing endometriosis earlier actually improve outcomes? Will it alter the natural history of the disease? We know very little about the natural history of the disease. We assume that a woman with severe disease actually started off with minimal disease at some point earlier in her life. Well, that may not be the case if minimal disease and severe disease are actually 2 different phenotypes. If currently women diagnosed with the disease are just the tip of the iceberg, and there are huge numbers of women that could be identified by some non-invasive biomarker, can the health system actually cope with vast numbers of women? And lastly, does the burden of disability, and I think the answer to this is probably yes, warrant earlier action? And from a health systems perspective, can we afford it? So in conclusion, the rather depressing news is that nothing much has changed, that imaging remains the only clinically useful diagnostic test, and that is primarily, as we have known for many, many years, concerns deep disease and endometriomas. Thank you.
Thank you very much, Professor Kennedy of Oxford this time. And we have we have room for questions. Anybody has any questions for Professor Kennedy? I probably can ask one. So
Richard, this is Richard Kennedy, my younger brother.
Go ahead.
Thanks. Thanks, Stephen. My question is this: given the long-term implications for the woman of either a false positive or a false negative diagnosis, I'm still left questioning what is the gold standard. And I guess the supplementary question to that is, because I think probably laparoscopy combined with imaging and a very competent, shall we say, bimanual examination, with that combination, that would, to me, would be a gold standard. Then what's your view with regards to peer review of a video of the laparoscopy? Because we all know you go in a second time, or you receive a laparoscopy that a colleague has done previously, and you find either nothing or something, but a contrary diagnosis. So,
well, could I deal with the second question first? Enda McVeigh, whom some of you know, who led our laparoscopic surgery team for many years, was absolutely adamant years ago that we videoed every single pelvis. And we used to give the CD to the woman at the end of the operation, so that she knew exactly what had been found and what had been done surgically. I don't know to what extent that is practiced elsewhere, but we did it years ago. And I think it's a valuable tool for the woman to use. So, to answer your first question, Richard, I don't know. I mean, what is the value of finding a speck of endometriosis in the pelvis? When I used to do laparoscopies regularly, I mean, you could find a speck of endometriosis in virtually every single pelvis. What is the benefit of then telling a woman, you have a disease? Is minimal, those few spots, accepting the fact that there may be deep disease underneath? Of course I accept that, and hence the value of a good bimanual examination. But if it is just superficial peritoneal disease that may be a transient phenomenon, here today, gone tomorrow, what is the value to that patient of labeling her as an endometriosis patient? I don't know. I really don't. But I fear that we may be doing more harm than good. That's a personal opinion.
I have a question. So what's your take on dynamic ultrasonography as part of the diagnostic armamentarium, with the accumulating data about its utility to detect?
When you say dynamic ultrasound?
The gel sonovaginography, dynamic ultrasonography, where you try to use maneuvers to see if there is cul-de-sac obliteration.
I'm not familiar enough with that literature. I'm not.
Okay.
I'm not.
Yeah, the Australian groups are publishing a lot about that lately in the ultrasound journals. And there are some centers who are implementing it, particularly in the context of advanced disease where they don't have access for MRI.
I think I've probably been spoilt in having really good access to MRI.
Okay.
Yeah.
Thank you. Well, thank you very much, and we appreciate your contributions.
Good evening, Doctor. Before I take the pleasure of introducing our next speaker, I would like to express my deep thanks to the organizing committee for their kind invitation. And now, on behalf of myself and everyone present at the session, I would like to welcome our next speaker from USA, Professor Shawki Badawi, Professor, Department of Obstetrics and Gynecology, Professor, Department of Pathology, Director, Reproductive Endocrinology and Infertility State, University of New York, Upstate Medical University, New York. The topic about teenage endometriosis.
I would like to thank the organizers of the program, Professor Dr. Sarur and Professor Dr. Shalakani, and also Madame Azza al-Turki. The presentation today is about teenage endometriosis, and I have no potential conflict of interest to report. Ancient Egyptians recorded some of the medical history as well as other historical events in their temples and monuments. And here is one of those recordings where the patient is a young lady who is in agony and pain, could be due to endometriosis, but we don't know that. They did not know that either. They are infusing some fluid on one of the veins and taking some blood from the other vein. It's of use from time to time to take stock, so to speak, of our knowledge of a particular disease, to see exactly where we stand in regard to it, to inquire to what considerations the accumulated facts seem to point, and to ascertain in what direction we may look for fruitful investigation into the future. This applies to endometriosis, which is a disease in which the endometrial glands and stroma grow outside the uterine cavity. It could be in the pelvic cavity, it could be in the abdominal cavity, it could be in the chest, and accordingly, the symptoms will reflect on these presentations. Teenage endometriosis affects about 8% or more of teenagers, and mapping studies of endometriosis in the pelvis have shown no increase in the disease with age. Before the introduction of laparoscopy for evaluation and for treatment of patients with pelvic or abdominal disease, it was difficult to make a diagnosis. Therefore, the data before 1970 were difficult to diagnose the disease, and people thought that it doesn't exist for teenagers. However, we know now that endometriosis can affect the pelvic cavity, can affect patients as teenagers. Why is that? Because now we could diagnose that very easy when we laparoscope those patients. That was not available before 1970. It's of use from time to time to take stock, so to speak, of our knowledge of a particular disease, to see exactly where we stand in regard to it, to inquire to what considerations the accumulated facts seem to point, and to ascertain in what direction we may look for fruitful investigation into the future. This is a patient who is 18-year-old, presented to me for consultation for treatment of severe pelvic pain and dysmenorrhea of 1 year duration. Pelvic exam revealed fixed bilateral adnexal masses, 5 to 6 centimeters each. Sonography was confirmatory. The diagnosis was bilateral ovarian endometriomas. And I'm going to show you that in a surgical procedure that we recorded for the program here. Before the introduction of laparoscopy, people thought that teenagers do not get endometriosis. Meigs, for example, in 1960 stated endometrial cysts are not found until 13 to 19 years of menstrual life. Let's say women who are at the age of 35, 40 or so get the disease. Younger patients don't get it. The introduction of laparoscopy made it clear that endometriosis could affect teenage population. Parsons in 68 stated endometriosis may occur occasionally in the 20-year-old girl. Harton in 67 stated 30 years experience, found only 12 teenagers with endometriosis. Laparoscopy and ultrasound enabled gynecologists to diagnose teenage endometriosis more frequently as a cause of pelvic pain. The River Nile. What are the symptoms of endometriosis in teenage population? Progressive dysmenorrhea, chronic pelvic pain of 3 months or more. There might be some other symptoms besides the pain, depending on the organs affected, like the intestines, for example. So you get some intestinal symptoms, or the bladder, and you get some urine manifestations. So you have to analyze the data to see what organs are affected. Chronic pelvic pain is a very common symptom, causes large number of absence from work. Laparoscopy should be done to diagnose the disease. What is the differential diagnosis of a young lady that comes complaining pain, and we think that she might have endometriosis? She could have pelvic inflammatory disease, twisted or ruptured ovarian cyst, lactose intolerance, irritable bowel syndrome, chronic constipation, and GU problems. After the introduction of the laparoscope in the late 60s, early 70s, and we started to do that to diagnose pelvic disease, we started to make diagnosis about endometriosis. Bullock in 1974 found 50% in adolescents with dysmenorrhea have endometriosis. Goldstein found 52.9%. Chapman, 65%. Versellini 38% of patients presenting with pelvic pain have endometriosis. These are the data of Vercellini. In 47 patients, 38.4% found to be having endometriosis. The rest have other problems. Emory from the United States here found 73% of these patients having endometriosis. The types of lesions are variable. There are many types of lesions. I'm going to show you some now from our patients. This is laparoscopy done, patient with pelvic pain, and you see she has clear cystic areas with hemorrhage as well as increased vascularity. That is endometriosis. Here, a patient with pelvic pain showing adhesions with vascularity. Hemorrhage subperitoneal, one of the manifestations. Scar tissue is one of the manifestations around the uterosacral ligaments. Hemorrhage at uterosacral ligaments. And this is a chocolate cyst or endometrioma from the ovary, and it ruptured during the process, and the chocolate material came out, which is old hemorrhage inside that cyst. This is the Mediterranean with the entrance to the Palace of the King in Alexandria, when Egypt was under the rule of the British rule. So to diagnose endometriosis, you take history and you know where are the symptoms. You do a pelvic exam to check if there are any enlarged ovaries or cystic swellings or whatever. Pelvic ultrasound and laparoscopy will confirm the diagnosis. Another cause of endometriosis is obstruction of the genital tract, either at the level of the vagina or at the level of the cervix, and blood collects in the uterus and goes through the fallopian tubes to the pelvic cavity, and endometrial tissue grows there, causing endometriosis. This is a patient with transverse vaginal septum, blood collecting above, causing marked distension of the upper uterus and going from the tubes to the abdominal cavity. That leads to some sort of endometriosis, and laparoscopy will confirm that. This is a patient where the cervix is absent congenitally and the uterus is filled with blood, and that goes into the fallopian tubes to the pelvic cavity and grows endometriosis. patient with septated uterus, and the cervix is not well developed, and the blood collects in the uterus. And we did hysterectomy in this case. This is another case where there is obstruction in the vagina and the blood collects up close to the pelvic cavity, close endometriosis. The treatment of endometriosis, there is medical treatment, there is surgical treatment. Medical treatment is based on the fact that the agents used will suppress gonadotropins and therefore they become hypoestrogenic and endometriosis will regress as a result of that. What are the elements used? Steroidal oral contraceptives, medroxyprogesterone, danazole, and GnRH agonist. All of them lead to the same thing, which is suppression of gonadotropins. Laparotomy is another line of treatment, and laparoscopy is another line of treatment in which you remove the endometrial implants and therefore you somehow cure the patient until it recurs again. This is another patient presenting, 14-year-old. I'm presenting those cases because you have to know that endometriosis occurs in a teenage population. I presented to you a 10-year-old. This is 14-year-old. She has lower quadrant pain. Laser laparoscopy showed the endometriosis and treated with laser twice. It recurred again until we excised it. And that helped to cure the patient again for a while because it recurs again. So the hypothesis for the development of endometriosis in the teenage, retrograde menstruation, if you have obstruction of the vagina, obstruction of the cervix, lymphatic or hematogenous dissemination, or coelomic metaplasia. I will show you now a case of endometrioma of the ovary that I spoke to you about and how we treat it. Here you see the pelvic cavity. These are the ovaries. One ovary on the right side showing endometriosis. And this is the left ovary showing spots of endometriosis. And this is an endometrioma. And these are adhesions between the bladder and the uterus. We're freeing them using the neodymium YAG laser. So we separated the bladder on the uterus, and there were some spots of endometriosis on the uterus. We treated them with laser. Here it is. And we irrigate. Well, this is endometrioma on the left ovary. It is small, and we use the laser to burn it out and vaporize it. This is one way of treating because it is superficial and small. I'm going to show you another one now, which is bigger, and tell you how we do. These are small areas of endometriosis on the ovary, other ovary. And this is vaporization of this endometrium using laser. This is the chocolate cyst for the endometrioma on the right ovary. It's large. See, when we wash it from inside, see the whole ovary will distend. And if we cut all that, patient will lose her ovary. So what I do is I separate the lining of this endometrioma and remove that lining, and therefore we keep the ovary with its cortex with the hundreds or thousands of follicles there. So this is the lining of the endometrioma. We're removing it and therefore keeping the ovarian cortex intact with all the follicles there, and therefore the patient could achieve pregnancy, and we succeed in that. After that, when we remove the endometrioma, it goes to pathology to confirm it, to be sure that it is endometriosis rather than any other disease. And the ovarian cortex is closed either with small 2 or 3 stitches, or it might be wrapped, the whole ovary wrapped in interseed, and that will allow the ovary to heal. And this is the endometrioma there. That will go to pathology. So endometriosis occurs in teenage population, and we have to make that clear. And thank you very much for your invitation.
It's with great pleasure that I'm introducing the next speaker, Professor Charles Chaperon. He's a professor of obstetrics and gynecology, University of Paris, France. You will address us about future of endometriosis. Is it a systemic disease? Professor Chaperon.
Actually, is one of. I just would like to comment. Actually, I'm not sure actually of the content of the presentation is going with the line that we were talking about, mostly about endometriosis over the yesterday and today. I mean, it seems that many of the things are being outdated, or you can say authentic, historical.
While we're getting ready for Professor Chaperon's talk, I have to say that Professor Chaperon is one of the leading researchers in this area for decades, was very valuable contribution in different directions, not only the clinical outcomes, but also it expands into the rare variants of endometriosis, including bladder disease, gastrointestinal disease, as well as adenomyosis, where he delivered one of his plenaries yesterday on that. And I think this talk is going to take us to the next level of what endometriosis is, about the fact that it has systemic involvements in different directions that we have to take in account when we are managing patients.
Possible to do by that also? Thank you. Thank you very much. Thank you very much, Mr. Chairman. I would like one time ago to thank Professor Gamal Siro for the invitation and all the organizing committee of this conference. So we are going to discuss together about the fact that to know if endometriosis is a systemic disease. I would like to thank all the people in the department in Paris who work with me for the medical management, but also the clinical and the basic research for the endometriotic and adenomyotic patients. So systemic means that these affect the entire body rather than a single organ or a body part concerning the definition. So we are going to answer to this question to know if endometriosis is a systemic disease. As you know, perhaps it doesn't explain all the pathogenesis of the endometriosis, but it's impossible to understand endometriosis without taking into account the implantation theory proposed 1 century ago by Sampson. Now it is well admitted that you have 3 phenotypes, sometimes associated in the same patient with superficial, OMA, and deep lesions. And in this large area of more than 1,000 patients operated for histologically proved deep endometriosis in the department, if we decided to perform the surgery, we perform a complete exeresis surgery. So for these 1,000 patients, when you perform a complete exeresis, you remove 2,522 histologically proved deep nodules of endometriosis. And this is very well demonstrated specifically for the intestinal lesions, 400 patients, and we remove more than 1,100 histologically proved deep lesions. It is the same for the ureteral lesions. That wants to say that the endometriosis, specifically the deep lesions, are a multifocal disease. And when you look at the intestinal lesions, what is very fascinating is that when you have a nodule in the rectum, this nodule is the unique nodule of deep endometriosis is only 10% of the cases. That wants to say that in your practice, when you diagnose a nodule of the rectum, that wants to say in 90% of the cases, you have other nodules located in other places in the pelvis. When you have a rectal nodule, in 50% of the cases, in our experience, you have an associated nodule in the sigmoid. And in 20% of the cases, when you have a rectal nodules, you have a right one at the ileocecal junction. This multifocality is very well demonstrated when we look at these lesions with ileocecal involvements, and it is a marker of the severity of the low rectal endometriosis because the mean total number of deep lesions is significantly more important, and you have also significant more ovarian endometrioma. Very demonstrative also when you look at the real ureteral lesions. 76 patients in this study, we remove more than 300 deep nodules. And what is interesting, that the mean number of deep nodules, without taking into account the OMA and the adenomyosis, is 4.6 for each patient. And in 80% of the cases, when you have an involvement of the ureteral, you have an involvement for the same patient in the intestinal wall. So if you want to perform a complete surgery for this patient, when you have a specific management of ureteral endometriosis, hand-to-hand anastomosis, or anastomosis in the bladder, in 80% of the cases, in the same procedures, you must perform the treatment, the surgical treatment of the intestinal lesions. The other point is that, as we said yesterday, that in a very large number of patients, as Professor Kennedy said, because of the possibility of the imaging process, we know that the patient very frequently present either at the MRI or at the transvaginal ultrasonography, diffuse or focal adenomyosis. And in these two studies performed in the team of Felice Petraglia in Florence in Italy or in our team in Paris, you can see that for young patients, less than 30 years old, with the imaging process, we diagnose associated adenomyosis in 30% of the cases. The second point which is important to answer to the question is to be convinced, and it is very important in the management of the endometriosis, that the endometriosis is really an inflammatory disease. And in the department, it was the PhD of my coworker, Santulli, we demonstrate that numerous pathways were dysregulated for the endometriotic patients, and all these dysregulation contribute to create in the abdominopelvic cavity an inflammation, and these inflammation contribute to the pelvic pain and pollution of the peritoneal fluid with difficulty for the sperm and the oocyte to have connection, so contribute also to the infertility of the patients. It is now the beginning of the story concerning the immunology and the endometriosis. And it is now demonstrated, you have some paper who look at the immunological disorder concerning the endometriotic patients. And recently we demonstrated that you have alteration concerning the phenotype and the function of the peritoneal macrophage. And we have a decrease concerning the phagocytic activity, an increase concerning the number and activation and production of pro-inflammatory cytokines. And the effect of these alterations of the peritoneal macrophage contribute to a failure to eliminate the ectopic endometrial cells and to promote the implantation and proliferation of the endometrial cells. And recently, we demonstrate clearly that the macrophage immune memory controls the endometriosis progression in mice and in humans. And a few years ago, we looked at the relationship between thyroiditis, dysmunity, and endometriosis. And we demonstrate in the PNAS that the thyroid hormone's metabolism is altered in the endometriotic patients. And we have a proliferation, and because of the loss of the thyroid hormone on the endometriotic cells, and these thyroid hormones will contribute and promote the endometriotic implant growth of in vitro and in vivo on the mouse. And this immunity, this inflammation process explain what you have a very strong association with numerous comorbidity for the endometriotic patients. And recently, in the United States, it was demonstrated that you have a strong association between the migraine and the endometriosis for the adolescent patient, and the risk of association is significantly increased when the migraine severity score is important. And in the department, we look at this association for the adult patients, and we demonstrate, we confirm the American results to say that you have a significant association between migraine and endometriosis. And what is new in our paper is that we demonstrate that this association is significantly more important for the more severe cases of endometriosis with ovarian endometrioma and or deep endometriosis. Because of this disimmunity, you have significant association between allergia and endometriosis. You have also significant association with the interstitial cystitis, and sometimes it's difficult to know what from the pain is due to the interstitial cystitis or to the endometriosis. Very interesting also in the daily practice, because it is very difficult to diagnose the fibromyalgia and to treat the fibromyalgia, and you can see that for the patient with or without deep endometriosis, you have significantly more fibromyalgia for the endometriotic patient with a major physical and mental impact for these patients. Very interesting, this very large cohort study in Denmark, who demonstrate the relationship between inflammatory bowel disease and endometriosis. It was observed for the ulcerative colitis and also for the Crohn's disease. And if you ask to your patient in your consultation if they have inflammatory bowel disease, you will find the association. But you will obtain the result only if you ask the question to the patients. And what is important for the follow-up of these patients is that this association exists more than 20 years after the diagnosis of endometriosis. Two recent meta-analyses go exactly in the same direction to stress the point that you have an association between endometriosis and irritable bowel disease. And this is also very difficult for us in our daily practice. What in the pelvic pain is due to the endometriosis and what is due to the irritable bowel disease. And now I try to work with gastrointestinal doctors, and we treat both the pain due to the endometriosis and also to the irritable bowel disease. And what is very interesting concerning the IBS is that you observe this association for all the endometriotic patients, but it is also observed for the patient without intestinal involvement by the endometriotic lesions. Recent study, very important study, performed in Finland, who demonstrate that you have an association between endometriosis and the risk of incident stroke. And you can see that whatever the multivariable analysis you perform, this risk is significant between 1.3 and 1.5. And the factors which are associated to this risk of incident stroke is the history of hypertension, the high cholesterol, hormone therapy use, hysterectomy with or without oophorectomy. And recently, the department we present these results at the CEUD meeting in Athens, and the publication is in progress. We demonstrate that we have a significant risk cardiovascular disease associated with the patient with endometriosis. So I think that this is very important for the gynecologist to build a specific follow-up of this patient in the future, because it is not only a gynecological disease. And recently it was published in the JAMA 2 or 3 months ago that you have an association between endometriosis and early natural menopause, and this was observed whatever the model you use for the multivariable analysis, model 1, 2, or 3. And it is now well admitted that you have a lot of comorbidity because of this inflammation and this immune disorder associated to the endometriosis. And what is important when you look at the pelvic pain of the patients with or without other pain disorder, you demonstrate that you have significantly more pain frequency, you have an average pain intensity which is significantly increased, and an average pain intensity in last week, which is more important. But what is very new is that the total length of pain per day for this patient with comorbidity pain disorder is significantly important. And this is important, why? Because you have an impact on the daily life of this patient with the length. You have not only the problem of the visual analog scale, you have also the problem, the duration of the pelvic pain episode per day. And more the length is important, more the negative impact concerning the daily life of the patient will be important for the family, for the domestic responsibility, for the professional life, and the social function. And you can see that when you have an association of different comorbidity, immune-mediated, you can see that you will have significantly more risk to have endometriosis. So, I think that at the beginning, the endometriosis is a disease of the endometrium. It is very well demonstrated 25 years ago that the endometrium of the endometriotic patient is not the same that the patient without endometriosis. And this endometrium has the possibility, because of the pathogenesis, to progress in the myometrium, with the retrograde menstruation to go in the pelvis. It's possible also to go in the right diaphragm or in the thoracopulmonary area. In the myometrium, you can have some adenomyosis. In pelvis, you can have gynecological involvement, intestinal endometriosis, urological lesions. In gynecology, you will have superficial, OMA or deep lesions, urological bladder and or sometimes associated ureteral lesions, and adenomyosis, you have the focal type and the diffuse form. And because of this immunity, you have association with numerous autoimmune comorbidity. And your challenge as gynecologist is during your questioning, you need to ask the question concerning this potential association to reinforce your diagnosis. And you have significantly more thyroid disease, systemic lupus erythematosus, multiple sclerosis, allergia, asthma, and so on. You have also stress-related comorbidity with more depression, anxiety, what the Anglo-Saxon call the chronic fatigue. It's completely true. The patient arrives in your office and she says, I am a chronic fatigue. I have to stop. You must take care of me. And you have also the inflammatory comorbidity with inflammatory bowel disease, more interstitial cystitis, and cardiovascular disease. So I think that these slides summarize completely and answer completely to the question of Gamal Serro. I think that today we can say that surely endometriosis is not only a systemic but also an inflammatory disease. And I invite all of you to come in the next meeting of SEUT in Abu Dhabi in next March to the 9th Congress of the SEUT in order to continue to share our knowledge concerning this fascinating disease. Thank you so much for your attention.
Thank you very much, Professor Chaperon. I think we have room for questions.
Professor Chaperon, actually, if I have a question, and actually this is related, actually you mentioned all the functional and dysfunctional, actually, systemic changes in various systems. So what about the predisposition to cancer as well in patients with endometriosis? I mean,
so it's a question we have very frequently in the daily practice by the patients. I think that we can say that the endometriosis is not a precancerous disease. We must say that to the patients, surely. So we have a very slight association, 1.2, 1.1, for the breast cancer. So it's very, very low. The only point is for the ovarian cancer, and the risk is not so high too, and it is for the old patients, and I think that either you have any doubt concerning the risk of cancer with the ovarian endometrioma, and you will manage not as an endometrioma, but a potential suspicious masses, but in 90% of the cases, all the OMA are benign, and we must reassure our patient concerning that there is no relation, there is no progression from the endometriosis to the cancer.
Professor Kennedy.
I fully accept everything you've said.
Thank you.
However,
I'm sure, because with Stephen is always the same. I agree with you, but
isn't there a risk of publication bias? You know, who's going to publish a paper, for example, showing no association between migraine and endometriosis? There is I think we have to accept there is a risk of publication bias.
I don't know. I think that we have numerous data who go in the same direction. We have the clinical observation, we have now some meta-analysis, and we have also immunological change. We have also demonstrated, not only our team, numerous teams around the world demonstrate clearly that the immunological profile of the endometriotic patient is not the same as the patient without endometriosis. So I think that, and it is exactly what I see in my daily practice. It is what is important. The risk, you have an association with the melanoma. That's true. Because these patients are pale, are blonde, I don't know why. But now I ask the patient, do you have disease of the skin? Because the woman, she doesn't go to the gynecologist to say, I have a melanoma. But if you ask the question, you will find some melanoma. If you ask the question, she came to you for infertility, are you some allergia? Have you some asthma? You will find that. But the gynecologist doesn't ask this question. And these elements are very important because the diagnosis is not so difficult to do when you are in an infertile context. But when we have the pelvic pain, it is not because you are a woman and you have pain that it is gynecological disease, and it is not because it is gynecological that it is endometriosis. So if you ask all these questions, do you have asthma? Now I find some problem of thyroids. 5 years ago, I never asked this question. And if you have some information, finally you will be sure that you are more in the field of the endometriosis. And now I take care a lot to the pain due to the fibromyalgia and due to the irritable bowel syndrome. And surely, I think it's better for the management of the patient between we manage both.
So you raise an interesting question. And the answer to which I'm not sure. And that is, are comorbidities as common in infertile women with no pain as they are in endometriosis patients
it's a good study
with pain?
We can do this study. We have to do this study. Yeah?
Because... Yeah.
I understand. It's a good question. You will do it.
I don't know the answer.
For the moment, we have not the answer, but perhaps it will be interesting to evaluate what is presented for all the endometriotic patients according to, finally, the clinical phenotype, endometriosis with only infertility, infertility and pelvic pain, and perhaps, I don't know, we will have not the same results. I think it's a good suggestion.
But by the way, I completely agree with you, your point about asking the patient. The more you ask, we did a study years ago on fibromyalgia pain, asking them about gynecological symptoms. Surprise, surprise, the findings were very similar to your own. If you ask, you find out.
You will find in medicine, you will find only what you ask.
Yeah, absolutely.
I think we have room for one more question. Professor Ahmed Darwish.
Thank you very much. Any correlation between the type of endometriosis and this big list of systemic disorders and the early menopause? For example, for endometrioma, it's accepted that for the early metriosis, part for the deep infiltrating. So any correlation between the type and the...
You are right. I think we are at the beginning of the story. Your remark is very, very good. We demonstrate for the migraine that we have more migraine. I have not the explanation for the OMA and for the deep lesion. But that's true that the preliminary paper are papers which are performed by epidemiologists, people. So they have a large number of data, they have a large number of patients, but they are not so well phenotyped. So I think that now we have this question. We need to go deeper in order to know, and I think we must take care of the classification, fertility and pain with or without, and also the three phenotype, and also to take care of the association or not to the adenomyosis. Because I have a PhD in my department who work on that, and there is a specific immune profile also for the adenomyotic patients. So I completely agree with you.
Okay, Richard Kay, yes, please.
Thank you. And my question is this: given the systemic nature, of endometriosis, with the exception of endometriometer and DIE, what's the place for surgical management?
It's a very interesting and difficult question.
That's why I ask it.
Not very gentle. I was educated, I am a surgeon. And and if you look at the paper we published 10 or 15 years ago, we published on the surgery and endometriosis. And now the recent paper during the last 5 years are completely different. And we are less and less surgical. We work a lot on to improve the quality of the diagnosis with the imaging, and Stephen doesn't speak of the questioning. We propose a score. With 10 questions, you are able to diagnose the patient. And I think that what you stress is fundamental, and I understand that 5 or 7 years ago. The problem is the endometrium. So when you perform the surgery, when you remove the cyst, when you remove the bowel lesions, you are the best surgeon of the world. You perform a bowel resection, a partial cystectomy, you leave in place the endometrium. The only 100% efficient treatment is the hysterectomy. This is the reason why. I can send you some paper if you are interested. We consider that now if the patient doesn't want to be pregnant, the first line therapeutic option is the medical treatment. And we demonstrate also, Garcia Velasco proposed that 10 years or 15 years ago in Madrid for the OMA, that you can perform the IVF without removing the OMA before, and we published 3 papers who demonstrate clearly that if the medical treatment is efficient with bowel endometriosis, you perform without surgery the IVF, and after 3 attempts, we have 50% of pregnancy. So I think that the problem in the future, sometimes you have no efficiency of the medical treatment, or they are not well tolerated, so it can be the place of the surgery. But we must stop to perform surgery for the diagnosis, to perform repetitive surgery. And when you perform the surgery, what you do after? You give the medical treatment to avoid the menstruation. So try first the medical treatment. Either you will systematically perform 2 treatments. So I think that in the future, we will continue to operate the patient, that's true. But we need to operate less and less to avoid the repetitive surgery. And it's only my opinion. I think that if the medical treatment works, we prescribe the medical treatment, and the key question is not when you perform the diagnosis, is when the patient wants to be pregnant. You perform a non-surgical diagnosis, you give the medical treatment for 5 years, she wants to be pregnant. You stop the medical treatment. If she don't want to be pregnant, you have the choice between surgery, if she's not spontaneously pregnant, or the direct IVF. And now we completely modify our management of the patient, and it goes exactly in the scope of the lecture and in your question, and you are completely right.
Thank you, Professor Charles Chaperon, for this actually very stimulating lecture. Thank you. Yeah, sure. We trained you. And actually, it's my pleasure to introduce our last but not least speaker, actually, Professor Mohammed Badawi from Canada. And as I mentioned, actually, he used to work at the Asyut University as well. And currently, actually, he's a professor and head division of the reproductive endocrinology and infertility in the Department of Obstetrics and Gynecology, Faculty of Medicine, the University of British Columbia, Vancouver, Canada. So please, Professor Mohammed, the floor is yours.
Thank you very much, Professor Amr, for the kind introduction as well as the kind invitation. While I feel small speaking among giants about endometriosis, but I'm trying to share something that we thought that's rare, but I don't think it is, and it's more common than what we think, which is the involvement of the fallopian tube in patients with endometriosis and how impactful that could be when it comes to treating infertility with endometriosis. So I'm going to share a combination of both data and a little bit of basic science and some surgical videos. Here are my disclosures. And here are the objectives that I am hoping to achieve to make you more informed about tubal involvement in patients with endometriosis, not in the macroscopic classical way, but also at the molecular level, and also to see how impactful microscopic endometriosis could be when it comes to the function of the fallopian tube, and finally, to share a case-based scenario on how to surgically approach that, if any. So I just want to share this video with you about one of my patients that I did recently, which you can see there. It's complete cul-de-sac obliteration, stage 4 endometriosis. And the fallopian tube is involved, quite involved in both sides, making an axal mass right and left. But if you notice that tube, despite the fact that it's quite involved, the fimbria is very much intact. And that tube is patent, but nobody can say that this tube can be functional when it comes to what it's supposed to do when it comes to infertility. So this is an extreme version of a fallopian tube involvement in patients with endometriosis that we all see all the time, and we tend to treat more aggressively in those patients, either surgically or otherwise. But if you look into this picture of a 31-year-old patient who otherwise have unexplained infertility, patent tubes bilaterally, macroscopically normal tube, healthy fimbria, the question would be, it's not showing there. I think I'm frozen a little bit. Here it is. That this tube really healthy, despite the fact it appears healthy and it's patent. So that's what brings me to this table about the prevalence of tubal involvement in patients with endometriosis based on different studies done in different parts of the world. And when we look at the macroscopic involvement that we can visually see at the time of laparoscopy, you have between 4 to 12% involvement. But for some of the studies that went on and took the fallopian tube that were apparently healthy at the time of surgical treatment, and they looked into under the microscope for those fallopian tube, the involvement of the fallopian tube is close to 44, 45%. One study 37, and the other study 42. And that's probably something we should think about when we treat patients, particularly if they fail treatment. So this is my first key message that I'm trying to communicate. Tubal endometriosis is not rare, it's there, but it's mostly microscopic in a large number of patients that we see day in and day out. So what is the actual impact of microscopic involvement of the fallopian tube when it comes to the different presentations of patients with endometriosis? But before I go into that, we all know, as Professor Chaperon and Professor Kennedy shared with us, that endometriosis comes from the endometrium one way or the other. So the question would be, what does the endometrium and the fallopian tube have in common? The first thing that they have in common is their embryologic origin. They come from the Mullerian duct. The fused part forms the uterus, and the unfused part form the fallopian tubes. But they are histologically different to a great extent when it comes to the microscopic structure. The second component, which is important from the functional point of view, that They share feature of hormone responsiveness. These are sections from the fallopian tube showing the expression progesterone receptors, androgen receptors, estrogen receptor alpha and beta, similar to what we see in sections of the endometrium. So, but on the other side, the fallopian tube endothelium is considered to be less hormonally active compared to the endometrium. And it also does not exhibit the same similar cyclic proliferative dynamics that we see in the endometrium. So the question is why? We don't have a full explanation for that, but there are some studies that showed that there is a higher expression of androgen receptor in the endosalpinx compared to the endometrium, which is something that will limit the proliferative and the secretory changes that could happen in the fallopian tube. So with that in mind, the questions would be, what kind of contribution the fallopian tube does have when it comes to endometriosis? First, it contributes to the origin of the disease according to Sampson's theory. There's a contribution to the pathogenesis of the different spectrum of the condition, and there could be a contribution to the different clinical symptoms, including pain, given the similar innervation to other viscera, and the crossover between the fallopian tube innervation and other pelvic structure, the clinical consequences of the disease as well. So we're all aware of the Sampson theory, and the key player in that theory is retrograde menstruation, in which the fallopian tube acts as a conduit to bring the retrograde menstrual blood into the peritoneal cavity. But it does it really act only as a passive conduit of that, or it contributes its part to the pathogenesis and the initiation of the disease? Probably something similar to what we know now about the stick lesions and their contributions to ovarian cancer, but this is beyond the topic of this discussion. In addition, similar changes happen in the fallopian tube, similar to what we see in the endometriotic implants when it comes to the different immune recruitments as well as production of different chemokines, cytokines, with the ultimate end of tubal obstruction leading to either hydrosalpinx or hematosalpinx. But pathologists share with us that there are three subtypes of tubal endometriosis. The first one, they call it type 1. It's the most common type that we see more often where it involves the involvement of the serosa and the subserosa of the fallopian tube, and typically coexists as part of a peritoneal disease. With repeated cycles of hemorrhage, that's when the tube gets blocked, and that leads to the hydrosalpinx. The second subtype, or type 2, is when the implants invade the mucosa of the fallopian tube rather than the serosa. And in some pathology books, it's called endometrial colonization of the fallopian tube. With repeated cycles of hemorrhage, that's what gives you another distension of the tube, but not with fluid, it's with blood, and that is hematosalpinx. So these are two distinct subtypes. The third subtype that we don't see a lot in infertility world is the post-salpingectomy endo, where the fallopian tube itself, the stump of the fallopian tube that's left behind in the patient after tubal ligation or after salpingectomy may localize a layer of endometrial-like tissue and start being enlarged and lead to symptoms secondary to tubal involvement. And there are specific risk factors for that, including the longer the duration after tubal ligation, the more likely that to happen. And contrary to what we thought, the shorter the segment of the fallopian tube, and the more likely that you use cautery to remove the fallopian tube, the more likely that you get that. So there are two different ends of the fallopian tube, the proximal end and the distal end. People who have a disease in the distal end, they are more likely to get the serosal involvement, or type 1, that will lead to hydro. People who have the proximal end of the fallopian tube involved, they are more likely to have type 2 disease. So this is another message. There could be three clinically, pathologically, and clinically different subtypes of fallopian tube involvement in patients with endometriosis. The consequences are shared with the other forms of endometriosis, including infertility, pain, and ectopic pregnancy. But what makes the fallopian tube dysfunctional in endometriosis patients and lead to endometriosis? We all are aware of this, inflammation, obstruction, adhesions, hydrosalpinx. But this does not explain or give a mechanistic rule to the possibility of systemic disease, like what Professor Chaperon said, or other forms of poor outcomes, like poor obstetrics outcome. So I want to share two other mechanisms that are not spoken about as much, which is tubal dysperistalsis as well as dysregulated gene expression. So I would like to take you back to the earliest part of this century and introduce this pathologist, the Santiago Ramon Cajal from Spain, who was the first to describe, who is a Nobel Prize winner with other famous one, which is Golgi, of the Golgi apparatus. He discovered the interstitial cell of Cajal, named after him, which is a mesenchymal cell first discovered inside the mesenchyme of the gut, and it is responsible for communicating the autonomic nervous system to the tubes, to the smooth muscles, initially in the GI tract, the urinary tract, and lately it was discovered to be in the fallopian tube as well. So these are segments of the fallopian tube with that pacemaker of tubal motility inside the fallopian tube. In a study of 10 patients, not a large number, they found that these specific cells that are considered to the pacemaker of the tubal motility are sparse, damaged, and dysregulated, and that contribute to the disturbed tubal peristalsis that happen in patients with endometriosis. And that could be one of the mechanisms where microscopic disease could be affecting the likelihood of this tube contributing efficiently to reproduction and infertility. There's also dysregulated gene expression, specifically in the fallopian tube, with a lot of upregulated and downregulated mRNAs. So again, the contribution of the fallopian tube to endometriosis is not only mechanical or inflammatory, it could be at the motility dysperistalsis level as well as a gene expression level. That is one of the meta-analyses we did recently, where we looked into the association between endometriosis and ectopic, and it's twice as much in patients with endometriosis. The diagnosis is almost always incidental when it comes to tubal endometriosis for the earlier part of the disease at the time of laparoscopy, but we know, we see that when it happens to lead to when it leads to hydrosalpinx or hematosalpinx. The management of the macroscopic part is usually or essentially surgical, but for the microscopic part, nobody knows. So I just want to share this video about this patient who is 33 years old, completely otherwise unexplained infertility patent tubes. And when we went on laparoscopically, you can appreciate here that the fallopian tube is stuck to the sigmoid colon. Not only that, the tube is completely patent with a healthy fimbria, but this fallopian tube cannot be functional in any sense when it comes to ovum pickup and doing what it is supposed to do. When you disconnect that fallopian tube from the sigmoid, as you will see shortly, you could see clearly that there is an endometrioma in the mesosalpinx right below the the fallopian tube itself. And in the later part of surgery, I'm not sure how much time I do have, you could see that we did excise that endometriosis and we spare the fallopian tube, and hopefully that fallopian tube would return its function without damaging the surrounding part of the fallopian tube. One of the things that we often see in those patients is very much advanced disease involving the rest of the pelvis, and when you do a beautiful excision with beautiful fallopian tube, as you can see here with good fimbria, if you leave that alone, it will be buried in the hole that we created in the pelvis. So one of the techniques that I suggest we should start using for patients with infertility is temporary ovarian suspension, as you could see here, where the ovary could be suspended to the anterior abdominal wall to give the peritoneum enough time to heal without allowing the fallopian tube to bury itself in this dissected pelvis and be obstructed. So you started already with a patent tube. You don't want to end up with a damaged tube at the end of your surgery. So, and again, as part of that surgical effort, you are trying to improve the patient endometriosis fertility index, particularly if they are considering spontaneous conception or intrauterine insemination. So this is another key message, that laparoscopic excision sometimes helps patients to improve their fertility index and improve their tubal function to optimize their chances of spontaneous conception or conception with IOI. So in conclusion, when it comes to a microscopic disease, it's quite prevalent, more than what we thought, and it's likely underreported, but unfortunately we do not have any data on how to approach that or manage it. On the other side, with macroscopic disease, I think there is a rule. If the tube is severely damaged, it's better to take it out if the patient is considering IVF. But if the tube is spared and the disease is in the mesosalpinx or the side wall, better to remove that and try to optimize the pelvic anatomy and the adnexal anatomy. With that, thank you very much for your attention. I'm happy to answer questions, if any. And
thank you, Professor Badawi, for this nice presentation. And now we can open discussion if there's any question.
I mean, one of the things that we frequently see is the, for the tubal endometriosis, is actually when we have the congenital obstructive lesions of the genital tract. So I think that actually is something that, to some extent, actually explains the importance of the retrograde menstruation. And what I actually would like to ask you that the altered motility as well is one of the factors for retaining the retrograde menstrual blood within the tubes, and probably distal obstruction as well. As a consequence, for example, for the peritoneal disease is another reason for actually having this tubal endometriosis.
I can't agree with you more about that, and I think the tube could be dysfunctional before it gets blocked. And the dysfunction of the fallopian tube before getting blocked is what is probably one of the leading causes of why these patients are not getting pregnant the natural way. So what we do with it, I don't think we have any data, and I cannot speculate, but it's something open for more research. Hopefully when we can have a non-invasive method of diagnosing endometriosis, we can pay attention to the tube before it's severely damaged in patients with endometriosis, and consequently we can counsel our patients to start trying to conceive way earlier than they should be.
Professor Badawi, I have a question. If there is any correlation between pelvic endometriosis and tubal hypoplasia?
Tubal?
Hypoplasia.
When you say tubal hypoplasia, you mean?
The wall of the tube is congenitally weak.
Well, I'm not aware of any data to make that link, to be honest. I just don't have an answer for this question. Professor Ahmed.
As regards the microscopic one, this takes us back to one of the first presentation about the endometriosis adolescents.
Yes.
We should start medical treatment very early whenever we suspect or diagnose endometriosis in these adolescent teenagers. So I think microscopic tubal endometriosis may be a progression. So if we can inhibit it by the medical treatment, this will give a better chance for this young lady when she marries. What do you think?
A great point, actually, and that's what we're exactly doing in Canada now. There is a campaign that was funded by the Canadian government to go to high schools and start screen girls who are quote unquote having dysmenorrhea while they are actually could be having early endometriosis, and try to just triage them a certain way and make them well aware of the disease and start the treatment. So Professor Chaperon shared with us the potential mechanisms for endometriosis being a systemic disease, and one of them is to have some microscopic migrating lesions in different parts of the body. Actually, we go far away to go to the brain and the heart and other structures, and like the GI tract. The tube is next door and it could be involved. It's not a vital organ, that's why it's not receiving the same attention the same way the nervous system and the cardiovascular system is receiving the same attention. Professor Kennedy?
Could I just extend what you've just said? As you may know, a lot of my work was in the field of the genetics of endometriosis, and therefore the answer I'm going to give is based upon the very strong likelihood that a family history of endometriosis is a major risk factor. And in clinical practice, my recommendation to anyone, any young girl with a family history of endometriosis was go on the pill, take it as early as possible, and take it continuously. Do not menstruate until such time as you wish to have children. Now, that's not evidence-based, but it's the least I think one can do for someone who is at high risk of developing the disease because of a strong family history. And I don't know of any other rational treatment or management approach to such high-risk women.
I can agree more with you about this, Professor Kennedy, and the fact that birth control pills has been around for decades, safe medication, people taking it right and left for different indications. And I think it's time to move to prevention rather than waiting for the obvious picture of advanced disease to show up later on in life, or for one organ to be dysfunctional to start treating. And lots of these patients already use other methods of birth control. With a little bit of counseling, they can probably use the proper method that not only prevent pregnancy but also control the progression of such a severe disease.
Well, thank you, Professor Badawi, actually, for this very interesting presentation. And actually, we came to the last minute of this session. I would like to thank my co-chairs, Professor Badawi and Professor Aglan, and I would like to thank all the attendants for being with us for that time of the day. And I think actually that the next session will start immediately. Thank you all for attending.
Much of an attendance, yeah. Not much of an attendance. Hello, we're doing. So we'll start right away. Okay. Yeah, that's fine. We'll start our session titled IVF Gamete Development and Banking. I'm very honored to co-chair this session with Professor Silber. Welcome to Egypt, Professor Silber. And of course, Professor Klaus is part of Egypt, so you are here more than I am. So yeah. So Professor Klaus is going to talk about past and future reproductive medicine. Professor Klaus is a PhD obstetrics and gynecology, and since then he has been the first consultant Department of OBGYN, University Clinic of Bonn, founding member of the European Society of Reproduction, of course. And we're very much excited to hear your presentation, Professor Klaus.
Okay. Thank you, Mr. Chairman. And crowded room. So, first of all, I want to thank Kamal Selvour and the other chairman of the organizing committee to invite me again to Cairo to this important meeting on fertility and sterility. I have the pleasure also to participate in the first meeting, which was about, again, 28 years ago. It was in the Nile Hilton, and I really enjoyed to come to Cairo every year since that, except the last year when I had the corona disease. So, the first slide, please. I don't have any conflicts of interest. And this is Lübeck, which is a very nice and old town at the Baltic Sea in northern Germany. It's not as old as Cairo, but about 800 years. So we always dreamed of creating a human in a test tube, and also the famous German poet Goethe gives some examples how to do this. But however, this was not the truth. It took about another more than 200 years that these two gentlemen, Patrick Steptoe and the biologist Professor Edwards, reported about the first delivery after an ovum pickup and fertilization in vitro and embryo transfer. They only wrote a short letter to the editor of Lancet and reported about this important pregnancy, and we all know what happened afterwards. And Professor Edwards was one of the motors in reproductive medicine, and many milestones, as you can see here, were influenced by him. Not only the first in vitro fertilization baby in 1978, but also the influence on ovarian stimulation with agonists and antagonists, cryopreservation, recombinant gonadotrophins, PGD, pre-implantation genetic diagnosis. He also influences also in vitro maturation of oocytes and embryonic stem cells. So he was the leading figure, for me, the mentor and father of reproductive medicine. And in 1984, he had the idea at the IVF Congress in Helsinki to found a European Society of Human Reproduction and Embryology, because he thought, and I think he was right, that many of the new ideas, IVF or all the other things, ovarian stimulation, they came from Europe and not from the States. So therefore it was important, excuse me, German, to create this European society. And he gathered European scientists and clinicians in Helsinki at that time in '84, and we found the European Society of Human Reproduction and Embryology, short as ESHRE, and everybody knows it. So the aims of this important society were to study and discuss all aspects of human reproduction and embryology, and 3 journals were published, and Professor Edwards was the editor of all these journals: Human Reproduction and Molecular Human Reproduction and Human Reproduction Update. And especially the last one is the most cited journal in this field of reproductive medicine. We also founded special interest groups, and we made guidelines and had our annual meetings and workshops. The last meeting of ESHRE was in Milano with more than 15,000 participants. So it's not a familiar meeting anymore as we had it in the beginning. We had the privilege, after founding this European Society, to organize a first meeting in Bonn in 1985. And I organized it together with Bob Edwards and Jean Cohen. And it was an early meeting. We had only about 750 participants. In comparison, we had, as I mentioned, 15,000 in Milano this year. And as a welcome reception, we could shake hands to every participant. You can see here Patrick Steptoe and Bob Edwards, Jean Cohen, a bit slimmer than afterwards, and also me on the right side. So we organized this meeting, and this was the first executive committee meeting which worked in 85 to 87. Bob Edwards was our chairman, and chairman-elect was Jean Cohen, and all the others who founded this important society. And I had a very close relationship to Bob Edwards. He was a very important man for me, and he visited us very often in Lübeck, in northern Germany, and I visited him also very often in Cambridge. So this is our group who worked in Lübeck with Professor Krebs. He was the head of the department, Professor Lehmann, our endocrinologist, and Professor van der Veen, Professor Alazani. I'm sure you know him. He came also very often to Cairo to this meeting, and also to organize the workshops together with you. And this is Dr. Hammerich, our medical assistant. So up to 2016, more than 8 million babies were born after IVF, and this is a lot. And the real figure, which is important, is the birth rate per cycle, not the pregnancies per cycle, but the birth rate per cycle. And this was about 26%. And when you see the figures of Germany, you can see that the pregnancy rate was lower, 21% only. This doesn't mean that we cannot do IVF, but the legal situation, and I will come back to this point, is even very bad in Germany, and therefore we could only achieve 21% live birth rate. But if you compare it with the natural conception rate and birth rate, it's about 24%, which is not much higher. And here you see the figures on the right side of the slide of the German IVF registry. We have about 100,000 cycles per year, which is a lot. But as you can see, there was a decline in 1994 when we got a new law in Germany called very modern law, which means that the patient has to pay half of the treatment themselves, which of course reduced the number of the cycles. And these are the pregnancy rates over the age of the patient. We all know that the age of the patient is the most important factor. And as we can see, with the age of 35, there is a decrease of the pregnancy rate of about 35% to less than 10% with the age of over 40. And of course, also the abortion rate is increasing with the age, as we all know. But it's important to show these figures. So there are some, especially in Germany, some ethical and legal problems with reproductive medicine. The question, are we allowed to select embryos? In Germany, not. And the pre-implantation genetic diagnosis was forbidden for many years in Germany. I will come back to this point. And also research on embryos and embryonic stem cells is not allowed in Germany because of our embryo protection law, and also oocyte donation and cloning is not allowed. So the German embryo protection law, which we have since 1990, which is very strict, so that many new developments could not get introduced in Germany. As I told you, we have about 80 to 100,000 treatments per year, and there are some problems with this law. We couldn't do it with unmarried couples, which is allowed now, and was also not allowed in homosexual couples, which is now much better, and not in singleton. And we have some small changes in PGD. So we had from the German Academy of Science, called Leopardina, we sat together for 5 years, and you can see the committee on this list. And we worked for 5 years and published a new embryo reproduction law for Germany. This is a proposal, and it's very difficult for the politicians to follow this proposal, but I think it is very important, and we have to work on this very hard. And this law means that elective single embryo transfer should be allowed. This is the most important step to avoid multiple pregnancies, and it should be routine in Germany in every lab. And also sperm donation and oocyte donation should be allowed. Sperm donation is allowed in Germany, but not with IVF, but it should be allowed, and also, of course, oocyte donation. It should not be allowed that the German patients for oocyte donation have to go to foreign countries, mainly Spain. And also the shared motherhood, it was shown in the literature that there are no disadvantages for the children. So, of course, this should also be allowed. And the risk for female donors are today very low. So it should be introduced in Germany, of course, in a non-anonymous way. And we should adapt our law in Germany to the Swiss and Austrian law, which were described already. So just a few moments to the selection of embryos. It is easy today, without any genetic examination, only under the microscope, to select good-looking embryos with an implantation rate of about 30% or more, and also the irregular embryos with an implantation rate of less than 5%. And it could be shown by Garris first in 2005 that the pregnancy rate with a single elective embryo transfer are about 43%, which is very good, and only a low twin rate, which is also an important step. But you could also see that with the double embryo transfer, the pregnancy rate was not much higher, but the twin rate was about 32%, which is, of course, not what we wanted. This is the German embryo protection law. As I told you, we have this since 1990, which allows us only to transfer not more than 3 embryos. Of course, this is important, but every oocyte which is fertilized in the test tube has to be transferred, and we can only cryopreserve embryos, oocytes in the prenuclear stage, not embryos. Embryo freezing is not allowed in Germany. So at the beginning of IVF, every embryo was replaced to the uterus, and here you see the figures from Germany in comparison to Sweden. As you can see, in more than 60%, we transferred more than 2 embryos, sometimes 3, in comparison to Sweden, where they prefer the single embryo transfer, and about more than 60% had only 1 embryo transferred. And this is, of course, responsible for this figure. That means that the birth rate is higher with a singleton embryo transfer, with 26% in Sweden, and however the twin rate is very low, with 5.6% in comparison to Germany with 20%, because we have to transfer every embryo which we get in the lab. And here you see the figures of Sweden over the years, and the single embryo transfer was introduced in '92, and as you can see, about 70% have a single embryo transfer today, and so they could reduce, of course, the multiple pregnancy rate, but the pregnancy rate was the same with the single embryo transfer. So we have to follow this Swedish protocol. And here you see the figures from Germany from '97 to 2002. You see singletons 59%, and twin and triplet are nearly 40%, which is of course much too high, with a total of nearly 40,000 deliveries. And of course you all know the problems with multiple pregnancies. There are gestation-related diseases, premature deliveries, and higher neonatal morbidity and mortality. I have to speed up a bit. So we have to avoid these multiple pregnancies. And just to give you an impression about the discussion over PGD in Germany, so in the test tube, the embryo was protected and could not be touched. However, in the prenatal diagnosis, when the embryo is already implanted, is allowed in Germany, and of course also with the consequence of an abortion. So this was a contradiction, and it was very difficult to avoid this and to change the mind. But of course, again, with the German Academy of Science, we could influence the new law, and we could allow the PGD. And here you see the first baby of PGD, which was born relatively late in Germany, in Lübeck. This was in 2012. So just to conclude, we need a new law for reproductive medicine in Germany. Especially the single embryo transfer has to be introduced just to avoid the multiple pregnancies. And it is possible to do this only after morphological assessment. You don't need PGTA or something like that. So PGD is allowed now in Germany after long ethical and legal discussions. And we have to work very hard to entitle the women for the best possible treatment. Oocyte donation should be also allowed, as sperm donation is allowed. And just to summarize, progress in reproductive medicine is slow, but there are some progresses like time-lapse imaging and next generation sequences. Vitrification was a very important and successful step, and the fertility preservation in oncology patients. Thank you very much. Yeah.
Thank you, Professor Klaus. Do you have any questions here? Well, you have very strict laws in Germany, so
we have to work.
I agree that you need to change them. So.
Thank you.
Thank you very much. Professor Bakr Nashar, it's my honor to co-chair this session with him, and he's going to introduce
Yes, a well-known figure, Dominique de Ziegler, professor and university consultant, ART, France, residency in obstetric and gynecology, UCLA diplomat of the AM Board of Obstetrics and Gynecology. Professor de Ziegler will address endometriosis, a new indication for ART.
Right. Thank you for the kind introduction. I want again to thank Gamal and the organizing committee for inviting me here. This is a city which was home for me for several years when I was an adolescent. There's a problem with the slides. What we're going to try to do in the next minutes to come is to convince you that there were several indications for IVF. Klaus referred to the early days of IVF. IVF was designed for tubal factors, then it became indicated for male factors, and then it became widely indicated as efficient in unexplained infertility. And what I'm going to try to do now, if I have slides, is to actually convince you that there's a new indication for IVF, and that indication is endometriosis. You want me to give you a memory key? Yeah? And so, there are several issues to be discussed with that, and one of them is the diagnosis of IVF. There are, in the past 10 years, in the past 10 years, it's Cairo. Yeah, Cairo 2022, right. It's endometriosis. All right, don't touch it. Shukran. Okay. All right, in the past 10 years, 10 primary features. The first of them, these are my collaborators' disclosures. Endometriosis comes as a new indication for IVF, up and above what already exists. In the past 10 years, 4 primary features. First of all, new approaches for diagnosing endometriosis, and this is because endometriosis is not diagnosed by laparoscopy anymore, because we don't do diagnostic laparoscopy, so we have to have a backup option. There is in endometriosis a toxic pelvic condition on oocytes and embryos, and we're going to talk about that, and that's the essence of the indication for IVF. The effect of endometriosis on the eutopic endometrium, but we can walk around that. And actually, I'll show you evidence that implantation in endometriosis is unaltered. And finally, the effect of surgery on ovarian reserve. I will be very brief because there were discussions on this before. So, in essence, we used to diagnose endometriosis in infertile women, I'm talking about, by diagnostic laparoscopy, which was part of the workup. In an infertile woman, you would do a workup with, I'm scared about the time. Is it 11 minutes, the time?
It's 11 minutes, yeah, but you still have extension.
Okay, all right. So, we don't do laparoscopy, so therefore, we have to have a backup, and the backup is ultrasound and MRI. The second point is that endometriosis exerts a toxic pelvic effect. We had an article in FNS in 2018, and this is the start point of a new frontier for medical therapies. 3, receptivity. Receptivity is unaltered provided that you transfer the embryos while the ovaries are suppressed. And now they can be suppressed just with estradiol and progesterone using a frozen embryo transfer. Finally, surgery actually harms ovarian reserve, and in short, actually harms ovarian reserve more than the disease itself. When I was working with Charles Chaperon, who was in the room, we showed that surgery is really harmful on ovarian reserve more than the disease itself. And so we have to talk about the diagnosis. We'll make it very short. Endometrial receptivity and the practical management. We don't do diagnostic laparoscopies, and then we do laparoscopy, we don't do it like this anymore either. But if you don't do diagnostic laparoscopy and you don't diagnose endometriosis, the incidence is abnormally low. There's been a report by SART in the US indicating 11% in women doing IVF having endometriosis. This is not true. You have to have an alternate way of diagnosing endometriosis, and these alternate ways are two: ultrasound and MRI. The lack of laparoscopies has created a void for diagnosing endometriosis, and there is a need for a replacement option. There's been several publications, but the essence of the message regarding both ultrasound and MRI is the following. You have to have a systematic mapping of the areas where the disease is, and so therefore you can actually have a useful diagnostic tool. You see here, and since then, not much has been done. You have to look into every single areas where endometriosis might be and determine whether it is present or not. And this is true for ultrasound and for MRI. Not everyone does that, so therefore you have to have your referent people to actually do the right job. That's the same for MRI, and I'll be brief. MRI also replaces now with an efficacy that reaches the replacement criteria for diagnosing endometriosis, and as well as ultrasound. The biomarkers, however, the first one of them being CA125, the biomarkers are very interesting, including the microRNA, but they have not reached yet a replacement regimen, a replacement value, and they are used for research, but not clinically as a replacement. All right, so toxic pelvic environment in the pelvic cavity. The message is here. In vivo, fertilization occurs in the distal end of the tube in an environment which is actually bathing in the pelvic cavity, and so the sperm and the oocytes are exposed to the pelvic environment, and they are altered, the sperm and the oocyte. And that implies, that results, and we know from IVF that a very short contact with the sperm oocytes with a toxic environment can impact on the development of the embryo, including leading to miscarriages. This affects in vivo conception at home. But here comes IVF. As you know, 30 to 50% of women who are infertile have endometriosis. When you go to in vitro, you bypass the pelvic cavity. You recall the oocytes which are not exposed to the pelvic cavity, and therefore spared the toxic environment. And the sperm also is spared the toxic environment. This is the basis for the fact that now there is ample evidence that endometriosis does not alter, does not diminish the results of IVF. This is a work we did. As you know, you in Germany, you have your problems. In France, we have our own. we cannot do PGTA. Why? God only knows, and I'm not even sure he does. So we did the study in collaboration with a group in New Jersey. This is Richard Scott, and we actually studied to study the quality of oocytes, the haploidy of embryos obtained from women with endometriosis and women without. You have here the increase in aneuploidy with age, which is what you expect. But in each age group, the aneuploidy is the same in women with endometriosis and in women controls in dark blue. So in essence, and to be very short, the indication for IVF really relates to women that we see in IVF over the age of 30. We rarely see women older than that, although it may happen. And we have to remember that surgery can actually help natural conception. Surgery does not help IVF, and you have to have time to consider surgery. This is only for women who are young, because you have to wait 12 to 18 months to conceive naturally, and you have to have time for that. You have to have sperm, and you have to have patent tubes. But if you do surgery, it increases the chance of conceiving naturally. And again, the discussion as to who might be a candidate were held this morning. Endometrial receptivity. There is no question that endometriosis alters. It's also a disease of the uterus itself. It alters the endometrium of the uterus, the eutopic endometrium, and the essence of the alteration is a resistance to the effect of progesterone. Now, before we used to block ovulation for a long time with either the agonist or the pill, and we had done the pill when I was at Cochin, but now things have changed. We have assessed that frozen embryo transfers have implantation rates that are not altered as compared to women without endometriosis. This is the implantation rate, the positive ACG, clinical pregnancy rate, pregnancy losses, and live birth rate in women with endometriosis in blue, and the other two controls are women undergoing PGTM and male factors. So the hypothesis, this is not proven yet, but the hypothesis that we have is that actually blocking the ovary with estradiol and progesterone neutralizes these effects of endometriosis on the endometrium. The question of adenomyosis is one that remains a big issue. There are numerous publications, and some by Charles, who indicate that there is an altered receptivity. We, in essence, believe that if the uterus is anatomically normal and asymptomatic, there is no impact on receptivity. And actually, we did a consensus meeting on repeated implantation failures, looking at the outcome of 3,000 euploid embryo transfers over time, time after time. And actually, if you were selecting out people with a problem, you would have a decrease in implantation rate, and this is not the case. So altered receptivity in the general IVF population may affect at most 5% of people. I'm not talking about symptomatic adenomyosis or huge, humongous uterus. I'm talking about asymptomatic in a normal size uterus. Surgery is more harmful than the disease itself. This we know. And in essence, during the past decade, the role of surgery for managing infertility has changed. We don't do diagnostic laparoscopies anymore. Surgery has no proven benefit on ART outcome, including when you treat endometriomas, and therefore should not be performed before ART. Contrary to ovarian stimulation for IUI, which actually increases the risk of flaring the disease. ART does not. And the difference between the two is probably simple. When you do a stimulation for ART, for COS IUI, you have ovulation. And having ovulation, the content of the follicular fluid is actually spilled over in the endometrial lesions. And when you do IVF, you don't spill the liquid because you aspirate. There is no ovulation, if you will. You aspirate before ovulation. All right, so you have the reference if you're interested in this, and the practical management. Getting close to my time limit. So the practical management is way back at the time that you have an infertile woman, because you don't have the diagnosis of endometriosis most of the time, unless the patient is referred to you by an endometriotic surgeon, or because the patient has had a diagnosis made before because she had pelvic pain. But most of the time, you don't have the diagnosis. You may, however, have suspicion. And so, therefore, at the initial consultation for infertility in the prospect of doing IVF, you have three possibilities. A, you have women who have no symptoms and no suspicion of endometriosis based on history, based on the study that we had looked at with Charles, the incidence of dysmenorrhea, taking the pill during adolescence, and so on. If all of that is negative, then you don't have it. Then you have, at the right side, women whose diagnosis has been made before, and they have endometriosis. And you have all the women whose diagnosis is possible because they have suspicion, because they've had dysmenorrhea, and therefore you have to do a pelvic workup. And then they fall in either group based on the result of the ultrasound MRI. And now, if you have endometriosis confirmed, if the patient is young and she has time to undertake surgery and wait for that, particularly if there is an endometrioma just on one side, then you may consider surgery. Otherwise, you go straight for IVF and you don't do surgery. This is our recommendation. Now, there are exceptions to that rule as there are to every rule. In the case of a very large endometrioma, what you call large is up to you to figure out. In case of hydrosalpinx, and in case of pelvic pain. And with this, I hope I have convinced you that endometriosis has to be added as a new indication for IVF, up and above the one that you were aware of at the time that you created ESHRE. Tubal factor. Now, endometriosis is a new indication for IVF. Thank you.
Dominique, I just have it's too bad this is a small audience. I think it's the end of the meeting, because that was a great presentation. I want to ask you two simple questions. One related to something other than your talk. First question is, for adenomyosis, we know that a huge adenomyosis we need to correct for pregnancy. We do the OSADA procedure. But did I hear you say that minimal lesion adenomyosis, routinely picked up, doesn't have any impact on implantation rate? Fantastic. Can you say just exactly how big a difference, how big does the adenomyosis have to be to have an impact?
Asymptomatic adenomyosis probably has no impact on breast tissue.
Simple as that.
And overstated. We did a consensus meeting workshop. We do that on July 1st. The paper is now in press with FNS. We took 3,000 women undergoing IVF with PGDA and Richard Scott Bliss. And actually, we transferred euploid, frozen embryo transfers in Esodar and Vasocycle. And we did this over time when they failed. We repeated. There was no decrease in implantation rate. So in this population, the only qualification that they had a normal sized uterus by ultrasound. They had no solid, normal size uterus, and they were otherwise asymptomatic. We came down to, after 3, euploid, quote-unquote transfer, less than 5% did not become pregnant. So therefore, if it has an impact, it's absolutely minimal.
Yes. That's fantastic.
It's not in the direction of all the talks. I know that.
Your clinical observations have always been important for our work. That's one of them. Another one I wanted to ask, just because I have this opportunity, you gave a virtual video presentation, I think through IPSA, maybe 6 months ago, about progesterone in the luteal phase. I want to make sure I understand it well. Were you suggesting that the highest success rates were if the progesterone was greater than 30 nanograms per ml or greater than 20?
You opened a Pandora's box, okay? There was IM progesterone, and the Americans were using IM. The 10 best programs in the US were all using IM. If I'm French, I will say Americans use IM because they believe that if it doesn't hurt, it doesn't count. However, this is a fact. IM works very well, okay? And then the paper by Kate Devine was the first one to blow the whistle about the fact that vaginal may not do the work of frozen. Frozen, you need more, because you need to cover not just the luteal phase, but the increase in progesterone during the early pregnancy. And then the Spanish people came with their measurements of progesterone. The bottom line is you need more for frozen. If you do HRT for frozen, you can do a combo, IM and VAG, IM alone, but VAG is not enough.
Right. Okay, thank you very much. Any other questions?
Yeah, I have a question, President Ziegler. If we're dealing with an asymptomatic adenomyosis and we're doing a frozen embryo transfer cycle, so do you prefer the hormone replacement one or a natural cycle in these cases?
The principle is that probably if adenomyosis behaves like endometriosis, what you have to do is a HRT cycle, because probably this effects on the endometrium and likely adenomyosis not approved is probably linked to ovarian function. So you want to have the ovaries at rest. So in those cases, we don't do natural cycle transfers.
Okay, and any recommendations for the luteal phase in these cases?
For?
The luteal phase in adenomyosis patients?
Well, what we do in France, we do vaginal and sub-Q systematic. In Spain, they measure progesterone and then they look at the levels, and if it's not high enough, they add. In France, it would imply measuring progesterone on a Sunday. And you know what? In France, they go on strike if you ask them to work on Sunday. So it doesn't work. So we do systematically for everybody, vaginal and sub-Q, which you have in Egypt, you don't have in the US, sub-Q once a day.
Well, okay, thank you very much. Any other questions? Microphone, please. Use the microphone.
Yeah, thank you. In adenomyosis and giving HRT, in these cases in particular, would you like to give agonist in addition to HRT?
Well, I guess you really have to talk. Adenomyosis becomes a buzzword, I would say now. People talk about adenomyosis all the time. If you talk about asymptomatic adenomyosis in a normal sized uterus, I don't do anything else than I would do for endometriosis. It's just transfer in an estradiol and progesterone cycle the month after the retrieval. Now, if you talk about a humongous adenomyosis, then we don't have enough data. It's probably different. And the common sense would actually to put them on agonist for a month or two in between the retrieval and the transfer.
Okay, thank you.
Thank you very much. And now it's, actually I'll say the people that didn't come to this Paul missed out on 2 great lectures, and now we'll have a third one with Dr. Abdul Ramzi, who's professor of obstetrics and gynecology, faculty of medicine, Cairo University, and he also runs stem cell banking, and that's stem cell banking is a subject dear to my heart, so I'm looking forward to your talk.
Thank you very much, Professor Silver, Professor Bashar, our dear guests. My talk today will be something different than endometriosis and IVF because I have special interest in stem cells, and I was the first to introduce it in Egypt since 2006. And I have a conflict of interest. If the bank I'm going to mention, I'm the co-founder and a board member. So if we're talking about stem cell banking in Egypt, first a small introduction about stem cells. So in stem cells, we always say the younger the better. So the embryo has the maximum population of stem cells, I mean embryo in IVF lab. The fetus, especially in the first early pregnancy, do have a large population of stem cells, of high quality stem cells as well. As we grow older, we get less and less stem cells in our body, in the children, and more so in the adults and the senile. So where do we get embryonic stem cells? We get them from the surplus embryos in the IVF lab, or we abort the pregnant ladies to get the embryo and extract from them the embryonic stem cells. Of course, this is illegal in Egypt and in Germany and many parts of the world, including the US in the Bush administration, the Bush-son administration, and then Obama came and legalized the use of embryonic stem cells first for research and later on for controlled therapies. So intended abortion is a problem, and students come to have abortion to sell these young babies. So there's this caricature where this man said, "I died waiting for embryonic stem cell research to find a cure. What about you?" The baby says, "I was the embryo." So this reflects how ethical issues work in this way. So the stem cells, which is the code of replication of all our cells, we start by the embryo and the sperm. The embryo in the uterus grows to form the baby. So the code is passed on every cell of each organ of the body for the first year. As the person grows, as I said, we lose out the cells carrying the code. So the code must be kept in every organ to serve as a model for cells to divide alongside other cells. That's why we find the stem cells in all tissues of the body, more so in organs that need to be replicated actively, like the bone marrow and the blood cells. The less tissues that needs to divide, the less stem cells, like the brain, liver, and the heart. As therapy, the most effective stem cell therapy is alternative to bone marrow transplantation. So as stem cell therapy, the bone marrow dysfunctions like thalassemia, sickle cell anemia, aplastic anemia, or the bone marrow implantation like the hematological malignancies like leukemia, lymphoma, and multiple myeloma, or metastasizing bone marrow tumors. So in case of bone marrow aplasia, stem cells play an important role in replacement for or rejuvenization of the bone marrow cells to produce blood cells. In acute leukemia, following the therapy, whether by chemotherapy or by radiotherapy, where there's total ablation of the bone marrow, replacement by stem cells give the patient a chance. And we do work with the children cancer hospital we call 357 in Cairo, where we replace and collaborate in the stem cell therapy and replacement for the children. In case for multiple myeloma as well, after treatment, and in the patients with solid metastasis after chemotherapy and radiotherapy. As more research happened, more stem cell value in case of spinal cord injury, stroke, burns, heart disease, diabetes, multiple sclerosis, and Parkinson's disease. And as regards Parkinson's disease, the patients, famous patients, were Muhammad Ali Clay and Michael Fox. Michael Fox for the famous movie Back to the Future 1, 2, and 3. Both of them had Parkinson, and in fact, Michael Fox had his foundation for the research and development of treatments for Parkinson's disease patients using stem cells. For cardiac diseases, adult stem cells derived from non-heart tissue are transplanted in the damaged heart muscle. These cells are able to replenish the myofibrils of the heart, especially following surgeries like the bypass or the cabbage operation, as well as the valve production, all successful. And in Magdi Yaoub Institute in Aswan, they use this elaborately in their project CardioCell since more than 10 years now. They inject the stem cells following the cabbage operations. As for the spinal cord injury, we have Superman, Christopher Reeve, who has broke his neck in an accident related to his horseback riding at a young age. So he as well developed the foundation for the treatment of quadriplegia following spinal cord injury with use of stem cells. But in fact, this has to happen immediately after the injury. Older scars are very resistant to be treated with stem cells in cases of spinal cord injury. We do this on an experimental level in Cairo University in the neurosurgical department in Asr Al-Aini. As regards burns victim, stem cells play an important role to replace the damaged skin from the burns, and recently they have invented this cell printers. Is now a reality to replace the affected areas. The trachea as well, there has been research has done that we collaborated in, performed in Toma Laboratories in Italy, in collaboration with BioCell in Switzerland, and BioCell Boston, and Cell Safe Bank in Egypt, where we are involved in the cell culture phase of the research to recreate a short segment of the trachea to replace the damaged part. In non-fractures or non-union fractures in Egypt, stem cells play an important role. So we have collaborated over 14 cases with the orthopedic department in Asr Al-Aini in Cairo University for non-union, resistant non-union fractures using the rescue. Rescue is by a company called Thermogenesis, which is a division of GE that we work with in the bank. So to replace or help healing of resistant bone marrow, bone fractures or non-reunion fractures, and the patients do well after that. The human embryonic stem cells are derived, as I said, from the excess embryos in the IVF lab and should only be used currently for research. But in severe intrauterine adhesions, these cells have lots of research to replace the intrauterine synechia following its resection and injecting the stem cells within the endometrium to form new endometrial cells. The mesenchymal stem cells that we use to call the Rolls-Royce of the stem cells, they have special functions that is self-renewal ability, differentiation potential, and colony formation. Mesenchymal stem cells are derived from the placental tissue, amniotic membrane, amniotic fluid, cord blood, and Barton's jelly. So that's why when we started the stem cell, we used to get the blood from the cord blood, and now we have the license to preserve the placenta, the amniotic cord, and the Barton jelly. So the mesenchymal stem cells have capabilities of secreting some trophic chains as growth factors and cytokines. Application of mesenchymal cell for treatment of various diseases is still in the research phase. in order to explore the complex mechanism between mesenchymal stem cells and various related causes of infertility, of female infertility. Still, further clinical research is needed to reach the consensus of using these cells in humans. Currently, they are only used for research in animals. In endometriosis, some reports that human umbilical cord mesenchymal stem cells that we get from the cord tissue inhibited the proliferation of endometriotic cells in vitro and promoted their apoptosis. In fact, the slide does not reflect the references I have put in the end note of the slides. Premature ovarian insufficiency following chemotherapy or without chemotherapy, but their experimental work has been done on patients with premature ovarian insufficiency exposed to chemotherapy. In mice, they have shown that transplanted stem cells can reside in the ovarian tissue and do something like homing. Homing means the stem cells will copy the cells beside it to save the ovarian function. However, these mechanisms are still experimental. Spermatogonial stem cells as well have lots of research now with variable results, but seems to be promising to produce normal morphologic characteristics in the testis and produce mature sperms. So where do we get the stem cells? Either extracted from the peripheral blood or bone marrow or skin or dentine of the teeth, or more available is the umbilical cord blood and tissue. So to get the blood, we are there during delivery. We clean the cord, we puncture the veins, we collect the blood in the blood banks by gravity, and we do labeling and packaging, pickup and delivery of the blood bank, and the stem cells are extracted from the blood and stored in the bank in metal storage cases, which are dipped by robotic arms in the bioarchive tank that we have that holds 3,600 cases, barcode identified and manipulated by the robotic arms. The pack is cooled gradually till freezing under minus 96 degrees centigrade in liquid nitrogen for 20 years. This is the bank in Cairo Alexandria Desert Road. It's not working. Anyway, you can see the liquid nitrogen tank, which is 2 stories high, with the ramp for the tank to come to replace or upload the liquid nitrogen. And this is the tank with the robotic arms, and this is the bank from inside, and we added another cryo tank recently. And we have now 4,700 cases stored, and we started tissue banking. We got the license in 2021, where we preserved the placenta and the cord tissue, and recently ovarian and testicular tissue, but our active participation in the live processing of bone marrow biopsies serving orthopedic and neurosurgeons in the OR. And we have recently, or not recently, in 2018, we have the license of the American Association of Blind Blood Banks. And as a conclusion, ladies and gentlemen, research has shown that stem cell therapy can treat degenerative diseases and repair damaged tissue. However, a number of aspects of stem cell therapy remain unexplored. Thus, vast untapped potential still exists with regards to application in treating diseases. And thank you very much.
Thanks, Professor Abdelmegid. If there is any questions for Dr. Abdelmegid, Dr. Iman Al-Gindi.
Thank you for your excellent lecture, as usual. Dr. Abdelmegid, you have personal experience, you or your team, about the using of stem cell in premature ovarian insufficiency or azoospermia?
No. Because
Please clarify this, because
it's still experimental, so we're not involved in experimental endeavors in humans or whatever. but there is a research مع مصر للتكنولوجيا الطلبة بتوع مصر للتكنولوجيا on animal models.
So what's going on is on animal and still it's experimental.
It's still
not to be
research
here.
work, yeah. But the more active is on the testes, in mice as well.
الأستاذ الدكتور عماد درويش.
Thank you, Dr. Abdelmajid. What about the ovarian tissues? Do you have any cases of the ovarian tissues in your bank now?
Yes, we have up to now two cases, oncology patients with Dr. Magdi Abdelazim, cryopreserved in the bank, and one testicular tissue.
One is kept by slow freezing?
Slow freezing.
Slow freezing.
Yes.
Or
And
vitrification?
No, slow freezing.
Slow freezing.
It's in fact, as I said, it's tissues and placed in the tank, and the robotic arms do the same process for the cord blood and cord tissue.
Thanks, Professor Abdelmajid. We can shift to the next speaker. Next speaker is Professor Sherman Silber. He will address in vitro maturation of oocyte from ovary, tissue, and ovarian longevity.
Well, okay, thank you very much. And I want to thank my wife for attending this lecture. We heard, we've already heard really some great talks that people have missed out on just because it's the end of the meeting and so no one shows up at the end. But we have a cozy little group, and I've enjoyed all the talks I've heard so far in this small session, so I hope I can contribute to it. This is really about fertility preservation for cancer patients. And we all know that we've done a lot of work on ovary transplantation since 1997, and it's now become recognized as not experimental, freezing the ovary tissue, transplanting it back years later, maybe 20 years later, after the woman has been cured of the cancer. And now I'd like to add something new to it that's developed from that. In vitro maturation of oocytes from ovarian tissue is something we've always wanted to accomplish, just to make sure there were no cancer cells being transplanted back. But it also tells us a lot about how the ovary works. So we've developed in vitro maturation as a simple, robust thing you can do any day, tomorrow, with very, very simple culture media, just by understanding how the ovary works that we learned from in vitro gametogenesis that I talked about earlier today. So the IVM from ovary tissue is very robust, much more reliable and robust than trying to retrieve GV oocytes from the ovary with a needle and then trying to mature them. And I'll explain why it's more robust. But first, I want you to just know what this talk is all about at the beginning, because it can get detailed and complicated, but all you really have to know is from this slide that I just generated to summarize it. We know that after primordial follicles are recruited, it's a 4-month period of time where they're not gonadotropin sensitive, and they are actually developing their meiotic competence. And we've talked earlier today about the exposure to 8 core genes that really do all the work. But there is no gonadotropin sensitivity. Now, after 4 months, they go through a different phase from what we call IVD to what we call IVG, where they are gonadotropin sensitive. And that is a very time-specific period of 11 days. And if they have been exposed to FSH during this critical period, for 7 or more days, then they are sensitive to HCG or LH, and they will go from GV to metaphase 2, normal M2 oocytes. But on the other hand, if they're exposed to FSH for longer than 11 days, then they're likely to degenerate because they're post-mature. So you have 4 days out of those 11 days exposure in which you can have competent meiotic competence develop in vivo or in vitro. It's all the same. And that accounts for a 35% maturation rate. So the GVs that we're able to get out of the ovarian tissue, we know with ordinary media, there's no special IVM media necessary because in vivo, everything that needed to happen has already happened in vivo. And there's no special media, and it doesn't matter what concentration of HCG or LH you use, you'll get the same good results. So that's just a summary. I'd like you to see this video. It'll impress you.
There's never been any doubt in my mind that I would be cured of this. Once I found out, I just made up my mind, that's it. You just have to keep taking it one day at a time and just keep that positive.
Can we turn up the sound? Is it turned up yet? Okay.
There's never been any doubt in my mind that I would be cured of this. Once I found out, I just made up my mind, that's it. You just have to keep taking it one day at a time and just keep that positive attitude and know that I can do this. I'll get through it.
It's 8 o'clock in the morning, July 17th, 1997. We're at St. Luke's Hospital, and we're about to do the first case in the St. Louis.
Oh.
There's never been any doubt in my mind that I would be cured of this. Once I found out, I just made up my mind, that's it. You just have to keep taking it one day at a time and just keep that positive attitude and know that I can do this. I'll get through it.
It's 8 o'clock in the morning, July 17th, 1997. We're at St. Luke's Hospital, and we're about to do the first case in the St. Louis area of ovarian tissue freezing.
Okay, well, I'm Dr. Silver, Sherman Silver, the Infertility Center of St. Louis, and we really have a treat right now. This is Jennifer, who at 24 years of age, I'm right on that, yes, came down with a terrible case of leukemia. They thought she was going to die, but just to be safe, in case she lived, and she did, and was cured, we would freeze her ovarian tissue. So that was like 20 years ago. And this is the first case that we ever did, and we're the only ones right now really actively with a program in the whole United States. And it's been a long time, and we didn't know that we'd be able to transplant the tissue back, and we didn't know if we could culture the tissue. And here she is now. We had her on Facebook Live several months ago, and she was happily pregnant, and now look what we have. Now she's 44 years old, if I can reveal that, with a 24-year-old ovary, and beautiful baby. What's her name again?
Madeline Grace.
Madeline.
So I just showed that because it emotionally grabs you and shows you the importance of freezing the ovary tissue, preserving the fertility of these young women with leukemia. She was a leukemia case, or lymphoma, or any of a variety of different cancers. And doing this, I'll summarize quickly the ovary transplant and get to in vitro maturation, which means not only can we transplant ovary tissue back, but if they're afraid of cancer cell transmission, which hasn't occurred yet, if they're afraid of that, we'll just have M2 oocytes for IVF. So this just shows you fresh human tissue before the freeze and the same patient after vitrification. But even slow freeze is safe. It kills some of the eggs, but not all of the eggs. And since they have so many eggs, I think there's no difference in result with slow freeze or vitrification. We just use vitrification for ovary tissue because it's easier. And once we thaw the pieces of tissue, we quilt them together. I think the surgical technique actually is very important for our high success rate of 76% of these women conceive naturally. And I think IVF is very difficult with these transplanted cases, and so it's important to try to let them conceive naturally. So the technique is important to quilt the tissue together ahead of time, and then when we do the transplant, to make sure that the fallopian tube can easily reach the surface of the ovary tissue and capture the eggs whenever they're ovulated. So all of our pregnancies so far with ovary transplantation, 76%, have been natural conceptions. And this is just a summary of those first 17 cases, and 76% pregnancy rate with delivery, 19 babies, and it didn't matter whether slow freeze was used or whether vitrification was used. The results were equally good with various types of cancer. And actually, just leukemia has always been thought of as not the disease you want to use because of the possible transfer of cancer cells. But indeed, we have 6 babies from 3 women with leukemia. And the secret to that is to freeze the ovary tissue after they're in their first remission, because the cancer cells in the cortex will have all been killed. But in the bone marrow, not so. So they're likely to come back for a bone marrow transplant or for a stronger chemotherapy. And so you don't have to worry about transmission of cancer cells generally with leukemia cases, as long as you froze the ovary tissue after the first remission. The ovary cortex just is not hospitable to metastasis. It's the densest, toughest, fibrous tissue in the body. This has actually been measured by anatomists in terms of trying to stretch the cortex. It's very much like the tunica albuginea in the male testes, which is known to be the toughest tissue in the body, tougher than the inguinal ligament or the Achilles tendon. And so it's not extremely hospitable to metastasis. But of course, leukemia cells do metastasize, but not very well. And then if they've had their first remission, the leukemia cells are dead. This was first shown by Klaus Andersen from Denmark. So this is our first patient, that leukemia patient you saw the video of in 1997 when she was 24 years old. And this is our second leukemia patient who had her tissue frozen 15 years earlier, and she now has 15 babies. 5 babies, but she wants to have 15 babies, and she still has the same piece of ovary tissue that's been functioning for 9 years, and we still have 2/3 of her ovary frozen that we haven't transplanted back yet. So most likely she'll be able to have children until she's 70 or 80 years old if she wishes to. And the summary of our ovary transplant results is we do have 30 healthy babies. And I think around the world now this has become so popular that there's over 300 healthy babies that are documented. But the in vitro maturation is exciting because it has profound implications, and it's so easy to do. It's not complicated like we once thought it was, and this is all based on in vitro oogenesis. So this is what we do. Once we've got the ovary out, and we take the whole ovary out, we don't just take out the cortex laparoscopically, we take out an entire ovary. We leave the other ovary intact because it's a perfect place to transplant the frozen ovary tissue back to 20 years later because it's right next to the fallopian tube. There'll be no eggs in it after their bone marrow transplant, but on the other hand, it's in a perfect position for an orthotopic transplant. Now, the recipe for IVM is shockingly simple. Ordinary culture media. Don't bother buying IVM media because whatever they put in there is no better than your regular IVF media. And we normally use 150 milli-IU per ml of HCG, but frankly, we've used a variety of concentrations from 10 milli-IU to 1200 milli-IU, and there's no difference in results. Results are equally good. And again, that's because the in vivo ovary tissue have already taken these eggs through IVD and through IVG, and it's just they're all prepared for HCG. They're ready to go. And so we dissect the cortex away from the medulla, but we don't discard the media, because that's where all the GVs are. The GVs that and of those GVs, there'll be 35% that have just completed IVD and are ready to be sensitive, IVD and IVG, and they're ready to be sensitive to HCG. So we have the thin ovary tissue we're going to chop into pieces and freeze. So we just cut them into pieces, and that's so we can freeze them. But then we don't discard the media. Then we look at the media after this corticomedullary dissection, and that's when we find the GVs. And this histology will show you what we mean. These GVs exist right at the corticomedullary junction. Now, I missed the opportunity with one of my first slides here to make the point that when the primordial follicles are recruited, they develop towards the interior, towards the softer medullary tissue, because recruitment of follicles is really triggered by lower pressure. And those 8 core genes are necessary, but the trigger is lower tissue pressure. So there's a gradient of tissue pressure from the outer cortex to the medulla, and the primordial follicles are just recruited in that fashion. And you're going to find the freshest, most recent GVs right at that corticomedullary junction, and they're very good quality GVs. And the reason that with tissue dissection we have such easy, robust results, whereas the results for years with needle aspiration were not very good with IVM, so it never became very popular. The reason is that you need FSH to stimulate LH receptors in the cumulus cells. Now, the mural granulosa cells have over 100 times the concentration of FSH receptors than the cumulus cells surrounding the egg. And so therefore, you don't just want to get the egg with its cumulus granulosa cells, you want the mural granulosa cells as well. So that's why these follicles that we're able to derive by tissue dissection are so powerful and robust, whereas when you do a needle aspiration, you're not as likely to get a good result or good M2 oocytes. So these are like the M2 oocytes we find in the spent media, and a day later, this is the GV with the compact granulosa cells, but then a day later you have competent metaphase 2 oocytes. And you can look at a whole series of them that we look at in different dishes, and it always comes to about 35% mature. But you can see in the upper oocytes that the top one is degenerated because it had been exposed for more than 11 days in vivo to gonadotropin. And the one that's a little bit next to it, which is just a GV, never matured because it had been exposed to less than 7 days of IVG in vivo. And these are just a summary of our first 14 cases, and I just haven't updated the slide yet. We have over 35 cases now, and it's always the same. It's approximately a 35% maturation rate, so we'll normally get 10 to 15 good quality M2 oocytes. And it doesn't matter what kind of media you use or what concentration of FSH or HCG. So many mature oocytes can be obtained from ovary tissue with simple media and no need for ovarian stimulation, but an intact cumulus is crucial. In one of the first cases, I can go right back to it, you'll see there that in the second case, we stripped the cumulus right away, which was a stupid thing to do, but we did discover that we got no quality maturation of M2s when the cumulus was stripped the first day. So, at any rate, there are other labs that have had the same robust results with widely varying IVM media. Klaus Andersen in Denmark and Seegers in Brussels, both great programs with very robust IVM maturation rates. It's just too bad that a lot of people aren't aware of this yet. And of course, Hayashi, who I work with on in vitro gametogenesis, has a 30% maturation rate. and it doesn't seem to matter what your concentration of HCG is. So the Anderson group also went so far as to do next generation sequencing of 53 of those M2 oocytes and 60, and you know that's very accurate because we're not worried about mosaicism when you're actually doing the sequencing, NGS sequencing of the oocytes themselves and not just embryos. And so these oocytes have a euploidy rate that's the same as you would normally find in a healthy young woman. And so by every measure, these are normal oocytes. And of course, there are live births we've already had from these oocytes. And the question is, why does it work? Why is it so easy? And why is there no special IVM media? And as I've said, GV oocytes dissected from ovary tissue have already become meiotically competent in vivo by what we term IVD and IVG. And it's far easier to obtain these many GV oocytes from tiny follicles using open cortical dissection than from using a needle, but also you need the mural granulosa cells as well as the cumulus cells. So that brings up the question, this is the profound part of it. I mean, if you're intellectually wondering how this incredible organ, the ovary, works, now we know that there are many GVs inside the medular cortical junction that have adequate exposure to in vivo FSH, and there are so many of them. 30 every day are recruited from primordial follicles 4 months earlier. And it's much easier to collect many GVs from these tiny follicles in your hand than in a needle, and 35% of these GVs have already been meiotically competent. So the next question is, why do you really need, I don't want to go over my time, why do we really need ovarian stimulation, and why do we in fact need the ovulatory cycle? I mean, many IVF programs in the United States thinks we have to give huge doses of gonadotropin in order to get better quality eggs, which of course is completely untrue. There is only one need, and this is a lot of words, and so I'm going to go through this more quickly. I talked a little bit too much. Yeah, this is the one you've got to concentrate on. There's only one need for the follicle, and only one need for ovarian stimulation, and that's to figure out a way to get the egg out of the ovary, because the egg is going to mature perfectly well inside the ovary without developing a big follicle that then explodes from the surface of the cortex, or you don't need a big follicle to make good quality oocytes. You just need that to allow for getting the egg out of the ovary. There's no other purpose for FSH. So we know we only need ovarian stimulation or the ovulatory hormonal cycle for follicle enlargement and normal monoovulation, or for oocyte retrieval. We don't need it for oocyte competence. So in vitro gametogenesis and IVM reveal the limited role of the ovulatory cycle and ovarian stimulation in oocyte development, other than simply to exit the oocyte from the ovary. So to understand how IVM works, you must understand in vitro gametogenesis. And that's why I want to really thank my collaborator for 9 years, actually, Katsuhiko Hayashi in Kyushu and now in Osaka. And we always refer to him as the X chromosome because Japanese are supposed to be short, but he's really tall. And Americans are supposed to be tall, and I'm really short. So he's the X chromosome of our pair, and I'm the Y chromosome. I went through this early this morning, and I don't want to repeat it, but I want to get to the final aspect of this. What determines ovarian longevity? Now, there is no such thing as ovarian rejuvenation because there are no ovarian stem cells, period. I know it's controversial, but our data, we've looked at thousands of ovaries, and our data is very clear that any cell that survived the fetal stages of oocyte development have already been exposed to retinoic acid with straw 8 being developed, and so they've all gone through meiosis, and there are no stem cells in the ovary. So tissue pressure regulates resting follicle recruitment and ovarian longevity. And let me see. Yeah, okay. So we knew this originally from our ovary transplants, where when the FSH comes down to normal after 4 months, the AMH goes up way above normal because there was an over-recruitment of primordial follicles with the release of pressure that came with the ovary transplant. And yet, with a very low AMH level, these ovaries will continue to function for many, many, many years, for over 10 years. This is the latest case we did, an ovary allo transplant. We required immunosuppression even, immunosuppressive drugs, and we always find the same phenomenon, that the FSH comes down to normal by 4 or 5 months, AMH goes up to excessively high levels, and then comes down to low levels, but then the ovary lasts for a long, long time. And that's because, I'll show you this, and that's because in the early fetus, the oocytes that manage to reach the cortex, which is the toughest tissue in the body, with the highest tissue pressure, are frozen. They're locked. They've gone through meiosis, and when they first enter the ovary by exposure to retinoic acid, and then they don't just continue in meiosis, because if they did, the little girl would be born with no eggs. So they're frozen, but at least the ones that reach the cortex are frozen. And this is the final point about ovarian longevity, is that the lower the ovarian reserve, the lower the rate of primordial follicle recruitment, again related to tissue pressure. And so you can have, once this ovary tissue has healed, and we have normal tissue pressure, despite an extremely low AMH because of the over-recruitment of primordial follicles, that piece of ovary tissue, which is about 1/3 of the ovary, is going to last for 10 years or longer. So I think my time is up, and well, I'm sorry, I just have to show you this. It's too exciting. So what is the mechanism? Why does the ovary cortex, which is high tissue pressure, freeze these follicles and make them dormant? And what is recruitment about at lower pressure, at the relative tissue pressure? And that's that when the high tissue pressure is similar to myogenic tension, which will cause any stem cell in the body to have the nuclei rotate. And the rotation of the nuclei slow down dramatically the rate of development. So you can see in the cortex, the nuclei are rotating, but in the medulla, they stop rotating and they develop. Again, watch carefully. In the cortex, the nuclei are rotating, but when they go to lower pressure towards the medulla, they're no longer rotating and they can develop. And so when we took these in vitro manufactured, so to speak, oocytes from skin cells to stem cells, they always went through meiosis very quickly. We had no way of stopping it. So whenever you got your mature eggs, you had to use them right away. So we wanted to see if there was a way we could freeze them, just like the human cortex does. So we cultured these oocytes in a high-pressure incubator. And in a high-pressure incubator, they stopped developing, and they were frozen in vitro, just like what happens in vivo. It's the dormant follicle is subject to pressure on the cumulus cells, which causes the nuclei to rotate and really basically locks those oocytes that are in the primordial follicles, and they need to be recruited by being at lower pressure. So what controls the recruitment of follicles in adults from the resting phase? A gradual release from the fibrous cortex. The most dense stroma is on the outside, less dense farther in, and least dense. This is the cortex even. So there is a cortical stromal density gradient that is what controls primordial follicle recruitment. And well, the only other thing I'd show is that pregnancy creates higher intra-abdominal pressure. And so during pregnancy, if you check the AMH level during pregnancy, normally every year it's going down. If you have enough samples like Terremoto had of 14,000 women, it's very dramatic and very robust. But then when you check your individual patient, you'll see that her AMH does not go down and it stays level. It doesn't go down as you would have predicted until 3 months after she delivers the baby. So again, this has been shown by McCready also in 2017, and I think I'll have to quit there, but point out that ovarian longevity, we now know, is related to the amount of tissue pressure in the cortex and the amount of eggs that you started out with, and there's a constant gradual release. But there are no stem cells. We've looked throughout, and there are no stem cells either in the cortex or in the medulla. So next time I come here next year, let's talk about ovary allotransplantation for Turner syndrome.
Thanks, Professor. Sure. Yes.
First, I want to congratulate you on this excellent results. GV rate or meiosis rate, 35% is excellent. Your results are excellent. But when you try to fertilize your meiotic oocytes, did you try to fertilize?
So no, actually, we're still collecting those M2 oocytes for the patient. So we're not going to be fertilizing our M2 oocytes until she's ready to get pregnant. It takes a long time. It took us 20 years just of ovary freezing to come up with the results we have now. However, there are people that have been doing this long before us, and they have healthy pregnancies from these oocytes. So, and also you saw that these eggs were all euploid.
Thank you. We can shift to the last speaker from Tunisia, Professor Mohammed Kharouf. Will address cumulating embryos using autologous oocytes.
Thank you, Mr. Chairman. I'd like to thank all the survivors here for being here so late. And my talk today is about a very special patient in the context of Tunisia. And in Tunisia, no egg donation is allowed. So sometimes we have some difficulties with those patients. So we have to take care of all the patients, but some patients have a really poor prognosis. And we know since the Poseidon classification that the normal patient with an expected response, we may take a pharmacologic action by increasing the dose. But those who are very difficult to manage are the patients with a real diminished ovarian reserve, with a low number of functional follicles. And if the prognosis is good for those who are relatively young, the prognosis is very poor for those who are aged more than 35. And obviously we know why, because of the aneuploidy rate, and we need, paradoxically, in those patients more oocyte to obtain the euploid blastocyst and to secure chances for pregnancy. But even for those who are young, if we fail to retrieve more than 2 or 3 oocytes, we have a very low chances also for a success in IVF. So today my talk is not about the young patient with acceptable low ovarian reserve. It's really about those who have extremely diminished ovarian reserve and the patient aged with low ovarian reserve. In those category of patients that no one wants to take care of, we have few solutions. Egg donation is not allowed in my country, in Tunisia, and all the techniques supposed to increase the number of functional follicles like the androgens, PRP, and or the stem cells and other stuff are from the domain of the research. And the classic attitude, the classic approach of having a high dose of gonadotropin and IVF, and sometimes we get an embryo, sometimes not, and then to transfer with low chances, is very costly and disappointing for the patient and leads to a high dropout rate in this category of patient. This has been demonstrated by Kobo in 2013, and we see here in this patient with low prognosis that at each new cycle we are losing 70% of the patient because the pregnancy rate is very disappointing. So what to do in this context? All those patients are coming to the office and asking for a solution. So that's why we are proposing this program of the accumulation of embryos to try to optimize the chances of one embryo transfer instead of doing some disappointing embryo transfer. So basically what we do, we use mild stimulation and we collect embryos and then we transfer it in a frozen embryo cycle, or sometimes in the second cycle we use the transfer of the fresh and the frozen embryos. We include the patient when reasonable chances cannot be achieved in one shot with conventional stimulation. We use mild stimulation in patients with a very low ovarian reserve or very low intrafollicular count, because when you have less than 2 follicles, it's the same if you use mild stimulation or high dose of gonadotropin, and all patients with failed or with history of failed previous high controlled ovarian stimulation, we try the mild stimulation. We do it in successive follicular cycle, not in duostim, because we find it easier for us and for patient. And we fertilize the oocytes because we want to know what is the potential of this oocyte to not freeze something that is not going to lead to an embryo. We generally use more frozen embryo transfer because we are using the clomiphene and we think that it's not suitable for endometrium. And we don't use PGTI because it's costly, and in Tunisia the law is not very clear and we are not sure that we are allowed to use it just for looking for aneuploidy. We are allowed to do it for the diagnosis. So basically it's the classic mild stimulation using the clomiphene, adding very low doses of gonadotropins at day 7 if we have an ovarian response. And after that we have some goals. Since we have no PGTI, so we are increasing the number of embryos. So if the patient is less than 35, it's 1 embryo. Between 35 and 39 is 2, the objective is 2 embryos, and for patient from 40 to 42, 3 embryos. I'm speaking about day 3 embryos. And when we reach the goal, we stop accumulating the embryos, and we go to the embryo transfer. So we have to verify if our thesis is feasible, is it efficient, is it acceptable by the patient, and also we have to think about the cost. So we have done a study, our center, the private one, and the public center. So it's a multi-centric study. So we included patients, as you see, less than 43, having an intrafollicular count less than 4, no amenorrhea, but history of poor ovarian reserve with the classic ovarian stimulation, or no oocytes. And as you see, the mean age is 37, and the mean AMH is 0.39 nanogram per milliliter. So we include this patient in this program, and we do multiple oocyte pickup using mild stimulation. It's in French here, but you see that 85% of patients obtained at least 1 embryo suitable for cryopreservation in this category of patient. And when we look to the results, we had 53 patients, and we had 20 cancellation. But at the end, 73% achieved their goal and had the embryo transfer, and we had a pregnancy rate of 39 and a live birth rate of 29 for for a group of patients who were asked to stop to go into RT. So some other author tried this kind of protocol, but with different inclusion criteria. This publication is, I think, from Indonesia. They have compared the classic attitude with the conventional ovarian stimulation and the multiple mild stimulation and IVF till reaching 2 to 3 embryos. But in this study, the AMH level was slightly higher than ours. At the end, they didn't show any significance when they compared the two protocols in terms of live birth rate. There was also another study from UK compared 3 cycles using natural cycles versus 1 conventional, and they have shown that in this population of patients having an AMH level of 0.3, that they can increase the number of oocytes and they increase the number of embryos in the study group compared to the control group. And this allowed a live birth rate of 30% in patients from 35 to 39, which was significantly higher compared to the control group. But it wasn't significant for the patients who were young and normal, because those patients doesn't need a lot of embryo to become pregnant. And finally, I found this publication, but I'm not sure what I think about, because they included patients with premature ovarian failure, which is, of course, looks incredible. And they did a lot of mild stimulation protocols, and a lot of, this is the number of the oocyte pickup complete by patients. Some patients underwent 18 oocyte pickup. And at the end, I want to believe, but it seems incredible because they are reporting 60% cumulative live birth in this population. I don't know what to think about this publication, but there is other more famous experience of accumulation of embryo. Of course, the paper by Kuang accumulating embryos with duostim and with mild stimulation, and of course the very famous paper of Ubaldi accumulating embryo with duostim and conventional ovarian stimulation, but they add the PGTI, which of course shortened the time to find the good embryo and diminish the number of the ovarian stimulation and the oocyte pickup. What about the cost effectiveness? The study from Indonesia showed that the protocol with freezing multiple cycles is more expensive, but we did a cost-effective study of our population in collaboration with a student from the Paris Sorbonne Abu Dhabi, and she postulated, we give her our data, and she calculated what happened in the patient from our protocol. We had in the group of patients, we had 24% of live birth, and she included 2 cycles of a patient having a low ovarian reserve using the conventional ovarian stimulation, 6% of live birth in the first attempt and 7% of live birth in the second attempt. And we give her all the cost of the medication, of the freezing, of the monitoring the ultrasound in Tunisia. And she calculated that the incremental cost-effective ratio per patient was less than the GDP per capita in Tunisia. So she concluded that this procedure is cost-effective in Tunisia, with the Tunisian, of course, costs of medication and medical procedure. I would like to finish with the patient experience. Of course, the controlled ovarian hyperstimulation in those patients is causing more distress than mild stimulation for obvious reasons, the cost, all the injection that the patient can avoid. And the dropout rate showed by Kobo in 2012 also showed that there was no dropout rate when the patient underwent the accumulation, because there's in their mind one goal, is reaching their goal in terms of embryo. So they finish the process until they have the transfer. The experience from our program is we felt like a patient-centered strategy, because here we care about the chances of an embryo transfer. We have to be transparent to explain the real chances. We have to also to have the courage to say stop if we have 3 or 4 oocyte pickup without any results. It's a long process and very painful sometimes for the patient, but also for us, because we have always to support those patients in case of no oocytes at the oocyte pickup or no embryo to freeze. So patients are very thankful, very, very thankful, because they have been in other clinics and the doctors told them that they have to go to egg donation in another country or to stop. And this is very rewarding for us, and it gives a lot of work for biologists. So the message is don't give up the fight. Maximize the chances of one transfer is maybe better, and we should have a reasonable cost of freezing. And I would like to finish with one of our patients, 37 years, AMH01, previous failed controlled ovarian hyperstimulation. She was advised to stop. She had 9 cycles of mild stimulation with us, 3 embryos, transfer of 2. She had live birth, and she came back 3 months after the cesarean section to collect again embryos because she wanted to become mom for a second time. So I'd like to thank all the patients for their courage, because this is not easy to go into this process, and all the staff and all the person who helped me to do this analysis, and thank you for your attention.
Thank you very much, Dr. Mohammed. Any questions or comments, Professor Ahmed?
Thank you, Dr. Mohammed, but I think you are depriving your patient from the chance of getting pregnant from the first transfer. What is the chance of pregnancy, the cumulative pregnancy rate with repeated, if you compare it with a single transfer with 2 or 3 embryos? I think the cumulative will be the same, the cumulative birth rate. You are adding the cost, you are adding time for those who can get pregnant from the first cycle. This technique is here in Egypt. Many of our colleagues are adopting, call it basket technique. But actually, I am totally against this basket technique. Especially, there is some studies saying that transferring freezed embryos in old age, in older age, has a less results from fresh transfer in this age group. I'm not speaking generally, but in this age group, the freezed embryos has less chance of pregnancy compared to fresh. So I think the cost is much. The only thing is that the dropout will be less, because you are keeping your patient with you for a longer time, hoping to a better result.
May I answer you? Yes. Yeah. So first, the results, I have shown the results. We had in those patients, when we still used the conventional ovarian stimulation with high dose of gonadotrophine, we had 11% of pregnancy rate. Now, with this technique, we have 33% of pregnancy rate. I know we are not comparing the same thing, yes, of course. No proper randomization. Of course. If you let me finish my comment. Thank you. Second, I didn't show all the results, but at least 70% of the patient had already previous controlled ovarian hyperstimulation in different centers, including us, and they failed to be pregnant, and they don't want to do it on the same way, injecting 300 of unite per day and having 1 or 2 oocytes. For them, it's not acceptable, and I understand that. So we have shown in these results, it's not comparative, I know. We should compare cumulative live birth rate with the classic attitude and the cumulative live birth rate with this process, but we have shown here that it's efficient and cost-effective in our practice, but it depends on the cost of each country. I agree, because freezing in my clinic is not costly, but gonadotrophins are very costly, so that's why.
Dr. Ayman.
Thank you for your lecture. For cases who I totally agree or like the term extreme poor responder, okay? For extreme poor responder, antral follicle count 3 and less. I think for AMH, 0.2 and less. Okay?
Those are my patients.
Okay, so for these cases, I think it should be in our practice, we shouldn't prescribe what I name aggressive ovarian stimulation or high dose ovarian stimulation anymore, and not to wait that to try this protocol first and then go for the soft. I think we should go for the soft. I want to take your opinion. I think you mentioned this indirectly, but I want to generalize this for all of us. I think for this category of patients, we have to go for soft protocol from the early beginning and save too much money for gonadotropin. What do you think?
I think yes, but now at the end, if you are 38 and you have only one embryo, with day 3 embryo, I don't think that you have all your chances to become pregnant. And if you insert vaginally for 15 days progesterone, or you inject, and you don't have all your chances, if you had already this experience, sometimes you want to have another experience and you would like to ensure at least 25% better than 10%.
By the way,
this is
I don't.
Look.
I
this
don't
is
disagree with him.
This is a patient-centered strategy. This is not a program to show his results or to have high results.
I'm talking about the stimulation issue. I'm not talking about your. On the contrary, in a degree, I agree with you, and sometimes, but you know from the beginning which type of patient you offer him embryo accumulation. One point, if I have not that good quality embryo, I will not go for accumulation because this not perfect embryo will not stand this.
I totally agree with you. Can we show the slide, please? Can we show my slide? I didn't put this because it was too long. I have only 50 minutes, but I put this strategy in the center. For all the young patients, the program initially is to have the fresh transfer, for sure. Only for those who had already used this strategy and didn't succeed. But for the other, it depends of the result. If you have 2 embryos with the first cycle, no need to do these techniques. But I'm talking with patient, you do the ultrasound, you see 1 follicle, and she's 38 or 39. What's the better? Is to start with stimulation to transfer in the better chances 1 embryo or to transfer 2 embryo. It's a patient-centered strategy. I agree. And I know it's controversial.
Dr. Hassan?
Yes, thank you. Well, thank you very much for a nice concept. Actually, I think we're mixing 2 things here. First, mild stimulation. I totally agree what you do, and I totally agree with Professor Iman. If this patient has 1 follicle or 2 follicles, if you give her 1,000 units a day, or give her 2 tablets a day, you'll get maximum the 1 or 2 eggs. So there's no point on going for aggressive treatment, and we totally agree with this. Although in our practice we usually use letrozole because we get a better endometrium with letrozole rather than chlomine. The other concept is, why freeze? Why not transfer? It might shorten the time to pregnancy, as Professor Ahmed implied.
Because when you have 1 embryo in a 38 years patient, day 3 embryo, it's not enough. We know it.
Yeah, well, 1
and second,
then 1 and then 1.
No, 2.
It's likely to get
2. 2 embryos, and then they get their embryo transfer.
I mean, if, let's assume you get 3 embryos, 1 of them is euploid.
Yeah.
If you put them together then the only euploid embryo will implant. It could be the first embryo.
I understand. I understand your question. I come back to it's a patient-oriented strategy. I mean, this is a mathematical point of view, which is correct. But if you ask your patient, they will tell you, I do no more want disappointing results using a lot of treatment and waiting for my ACG test. I prefer going with the same chances that the other patient who have a normal ovarian reserve. You understand? almost, I said 70% of those patients had already, of course, they didn't come to me for the as a first line. And of course, as a first line, I don't do this kind of strategy. I do this strategy in patients in which we failed to have, and they are looking for something different. If you transfer one by one by one by one, there is 2 weeks of treatment, patient with hope. You can say everyone will want 10%, she will believe that it's 90% of chances of succeed. And then disappointing, and that's why we have a high dropout rate in those patients.
I think it's very clear.
There's a debate.
To do
yeah, I agree. For patients who want, for example, to have more than one baby, for patients who want to have more than one baby, it's an interesting approach.
Yes, and we should encourage to do a comparative study between the two policies, putting in mind the time to pregnancy and the cost and the acceptance of the patient, and also the most important,
and the patient experience.
Yes,
yeah.
The cumulative pregnancy rate. At the end of this session, I would like to thank all the speakers.
Thank you so much.
And all of you, and thank you very much. Dr. Megid Ramzi.